morning, everyone. It's fantastic to see everyone on this great morning. I hope everyone had a great Halloween week. I just wanted to welcome you. My name is Rachel Lieberman. I'm the director here at the Celiac Disease Center. I work alongside my colleagues, one of which is with us today, who will be leading up our program, Dr. Ritu Verma, who is our Chief of Pediatric Gastroenterology, Hepatology, and Nutrition here at Comer Children's Hospital, as well as our medical director of the Celiac Disease Center, and a lot of other titles, including president of SSCD, amongst other things. So we are so happy. On behalf of myself and Dr. Verma this morning, I want to welcome all of you to this fantastic program. I would be remiss not to start. We have such a wonderful lineup of speakers today and colleagues who have given their time to give their talks as well as moderate today's sessions. It's going to be a fantastic program. I am here simply to give a few housekeeping. I know you've gotten a few emails from me, but please know if you are claiming your CME accreditation, there are instructions that were attached, and they're also on the program website on how to do that at the conclusion of today's program. I want to point everyone to the Q&A function at the bottom of yours, this Zoom, and that is where you can put questions. After each session, we will have a Q&A panel. And so we would love to create discussion with our speakers from each session. Please put questions you might have throughout. I also want to thank Karen and Eric Simon, as well as the Celiac Disease Foundation, for their support in helping us put this program together. It would not be possible without your supports. We're very, very thankful to all of you. And without further ado, I would love to introduce Dr. Verma, who will get us started this morning. But again, please utilize that Q&A function. And today's recording, it is recorded and it will be posted within 5 days of the program. Okay, thank you. Dr. Verma?
Thank you. Good morning, and thanks, Rachel. Welcome to our session here. It's the challenges and opportunities of the gluten-free diet. So for this morning session, I have my wonderful friend, colleague, past president of SSCD, and also the clinical director. He's the director of clinical research at the Celiac Disease Center at Columbia University, Dr. Ben Lebwohl. So Ben and I will be co-moderating this session, and we hope that there'll be a lot of fun chatter and questions in the Q&A. So bring it on, send us all your questions. We'll try and help and answer as many as we can in the Q&A session that will be at the end of this particular session. So I know everyone talks about the gluten-free diet as the treatment for celiac disease, and that truly is the only treatment currently. But do we really know what the gluten-free diet is? Do we know what are the pitfalls? Do we know what the challenges are, and what are the opportunities? And we hope by the end of today, we'll have some more insight. I know we'll have some more insight about the gluten-free diet. How do we manage? How do we monitor? What are all the things that we need to look at from a celiac standpoint? So I don't want to waste time here because we've got some wonderful speakers. So Ben and I will get this started. And our first speaker is Dr. Ann Lee. But before we go to Ann, Ben, any words?
I just wanted to say welcome and delighted to be part of what will surely be a lively day of presentations and Q&A.
Thank you. So Ann is going to start off, and Dr. Lee is an assistant professor of nutritional medicine in the Department of Medicine and Institute for Human Nutrition at Columbia University, and a dietitian who's a friend to all of us, whether we are in Chicago or New York or the Netherlands, or you're in India or wherever. Ann sort of leads the charge on many levels, and we are so fortunate in having her speak today and teach us and educate us about the gluten-free diet and a lot more, but really setting the stage for our conversation today. So Ann, thank you so much. It's wonderful to see you again, and take it away.
Thank you. It's always a pleasure to be here, and it's really an honor for me. So I will share and get us going. Um, okay, come on. There we go. All right, so my topic is really what is the gluten-free diet and how do we assess its nutritional quality? And I think that this is important, as Ritu said, is that we know it's the only treatment, but we need to dig in deeper and go beyond that. So to start, I have some disclosures, funding for grants and initiatives we're working on looking at the nutritional assessment of the diet. And so we need to look beyond. So introduction. To really discuss the gluten-free diet, we must kind of look back and say, okay, where did we start? And let's look at what's changed over time and look at how we need to then adapt how we're treating our patients and how are we assessing our patients and their nutritional status. And I know many of the other speakers will talk about assessing all those other aspects of their life as well. So if we kind of do a little history of celiac disease, ancient Greece is where really it was initially discussed and really didn't understand why some members of the family would fail and others would thrive when they're in the same environment and having the same diet. It wasn't until the 1880s where Dr. Guy really said there's an error in the diet and was able to at least direct, a modified gluten-free diet, if you will, consisting of bananas and rice. And we've heard about these poor banana babies, but it was a way for them to survive. And I like to think of that we've moved beyond that, but we'll talk more about that. It wasn't until 1950 that wheat was identified as that toxic factor in individuals with celiac disease. Now in the 2020s, we know it's an autoimmune response. We know there's an increased rate of diagnosis, there's greater awareness, but is that enough? And we're gonna talk about that, and I don't think it is. When we think of that gluten-free diet from 1950 to now, we really are moving along that measuring tape, but we focused initially very much on all those baked goods. So there were donuts galore initially, but let's look at that diet beyond those donuts. A gluten-free diet, in essence, should include many naturally gluten-free foods, your fruits, your vegetables, your proteins, your grains. Initially, not many products. A lot of the gluten-free breads and baked goods had to be made at home. But as we kind of move from the 1950s into the 60s, 70s, and even just the turn of the 2000s, we found there was a real shift. And it was a shift away from the focus on naturally gluten-free to many, many, many products and substitutes and replacements. And we found the diet shifted from the focus of those good, basic, naturally gluten-free foods to those that were packaged and processed. And indeed, when we look at the gluten-free diet, historically, we can track this shift in the global markets. And we found that in 2016, there were only 3.88 billion gluten-free products in the US. 2023, just last year, it doubled to 6.4 billion. And it's not just here in the US, but it's also the markets in Italy, in many countries in Europe and even in Latin America. We see this enormous increase in the packaged processed products. And Hanes data from the 2009 to 2014 survey really found that there was a huge increase also, not just in the consumption of products, but those people that would self-adopt a gluten-free diet without a diagnosis of celiac disease. It was only 0.5% in 2009 to 2010, and it jumped to almost 7% in 2013 to 2014. And, with the popularity of the gluten-free diet, the celebrity endorsements, the plethora of products out there, patients often come to us and say, can't I Google it? Can't I just follow someone on social media? Do I really need to see a dietitian? And the answer is absolutely yes, because yes, the gluten-free diet is the prescription for celiac disease now, but you need the dietitian to really look at how healthy is it? How can we guide you to really make the best choices? The gluten-free products contain, rice and corn and potato, where compared to gluten-containing products like a wheat-based bread, they have tons of nutrients that are then missing when we go to a gluten-free diet. So let's look a little bit closer at the differences in the nutritional quality of the gluten-free diet. So what we find is that a wheat-based diet by FDA regulations has to have the essence of the nutrients of wheat enriched back into any of those products. So your wheat-based flour is enriched with folate and your B vitamins. It's naturally high in fiber. Interesting, any wheat-based product must, by FDA regulations, must be enriched to meet these nutritional requirements. Dietary products or special products do not need to be re-enriched to meet the FDA standards. So what happens is that instead of having this plethora of grains and nutrition in your wheat-based products, when you transition to gluten-free, you're missing these. And what we find is often the gluten-free products, as we said before, are based on rice, potato, tapioca. They're also using starches to try to lighten the product rather than a whole grain flour. And to get the texture that we're looking for, or remember from a lovely wheat-based croissant, it's added oil, added sugar, added salts, many gums and things, so that the nutritional quality of that product shifts dramatically when we use a gluten-free product. Thank goodness there are some companies that are now starting to kind of relook at their ingredients, but for the most part, the nutritional quality of these products is less than the wheat-based products we had to eliminate. When we look at the concerns of the diet, we've seen there's been 3 very good studies over time that have looked at patients following a gluten-free diet. And Hallert was really a benchmark study done many years ago. And he was really one of the first ones to identify that for his patients that went on a gluten-free diet, yes, they did improve, but they also had signs of malnutrition in addition to increased weight once they started a gluten-free diet. And he felt that the weight gain was beyond that of just mucosal healing and now proper absorption. When he looked at the diet of his patients with celiac disease following gluten-free diet compared to the general population, he found that in terms of numbers of servings of different foods, it was a mirror image. However, then looking at the nutritional quality of the diet, he really identified that the bread was much lower in folate, B vitamins, and fiber. And he felt that and higher in sugar. And he felt that that was really the underlying cause for continued nutritional deficiencies in addition to unwanted weight gain. The study by Villette in the pediatric patients found the same thing, that the BMI measured at diagnosis and 12 months later, there was a huge increase, not just an increase in individual BMI, but also a shift from different BMI categories that were significant, where several patients went from being of a normal BMI into the overweight range and even to the obese range. And that was found also in the Convening study in 2012, that again, those biopsy confirmed patients, when compared to the general population, gained more than 2 BMI set points, which is again a significant unwanted weight gain. So when we look at that, we go and go, why is this big energy shift? In a study that was done in Italy, they looked at the intake of those following celiac patients following a gluten-free diet compared to the healthy population or healthy controls. And interestingly, the number of calories, or that total energy calculation, was the same, but where those calories came from was vastly different. The celiac patients that were following gluten-free diet are in the darker blue bars, and we can see that the amount of calories from fat and the amount of calories from sugar were significantly higher than the general population. And when we drive down a little bit further and look at that grain comparison, which is really the area of the gluten-free diet that is a shift from a regular wheat-based diet, we see that there's an increased intake in cereals, which are a highly processed food, and also in cakes. Interestingly, I found that this is an Italian study, the intake of pasta and bread was significantly lower in our gluten-free patients. But the worry part is that the increase in calories are from those refined processed products. So is there a solution? The current gluten-free diet is really kind of a concern on two levels. We have these nutritional deficiencies at diagnosis. Many of our patients are low in iron, low in the B vitamins, and then the current intake pattern then exacerbates that deficiency. And so we looked at this and said, well, how can we shift things and how can we make things different? And we really went and proposed kind of an alternate grain emphasis and really looked at if we change just the grain portion of our patient's diet, would it make a difference from a nutritional standpoint? So we took the standard food records from 50 patients and analyzed them and said, okay, if we take their standard diet of rice cereal, it was tapioca-based bread, white rice or gluten-free pasta, and their traditional kind of chips and cookies and donuts as snacks, and shifted it to a gluten-free oatmeal, a high-fiber gluten-free bread, and even just changed the grain at dinner to quinoa, and used a multi-grain flour to make a cookie, would it make a difference? And what we found is that not changing anything else in the diet, their beverages, their protein, anything else, we could make a significant difference. We tripled the fiber, doubled the protein, and quadrupled folate, iron, and calcium. And that's just by shifting those couple ingredients, really focusing on that grain compartment of the diet. And when we look at, kind of further dove into this, we found that if we looked at the number of processed products that our patients were eating, we found that many of the grain-based products were not just white rice, tapioca-based bread, but also even those other things, the cookies and pastas, were highly, highly processed. Using the NOVA classification of processed foods, again, looking at those same 50 patients, we found that there was a huge intake of highly or ultra-processed foods compared to those that would be a processed food like a pasta and those minimally processed foods. So that led us to, okay, we have these two concerns. One, many of the products are not, of high nutritional quality. They tend to be very processed, but we kind of have to look at the difficulty in following the diet. How easy is it to find a gluten-free product? How easy is it to navigate through your normal day, finding gluten-free alternatives as you're meeting with friends, doing a work lunch? And we found that over the course of the day, not only is it nutritionally difficult to follow the diet, but it's also hard from a contamination point of view. When we look at kind of a year in a life, or even if you look at it as a day, there are many times that, you're trying to do your best, but you're navigating dining out, you're navigating being told something's gluten-free, but was there chance exposure? You asked for gluten-free pasta, but you didn't get it. So that we have this double-edged sword for our patients where they're trying to navigate through normal of really a wheat-laden world, as well as nutritionally not having the things that they really need. So what could we do? What are the current guidelines? How can we make life better for our patients? And we looked at this and said, okay, what are the guidelines? The ESPGHAN guidelines now do a diagnostic criteria. If the TTG is over normal, there's no longer, the HLA required. NASPGHAN actually recommends access to a dietitian to assess diet adherence, not necessarily education. The British Society says follow up with a dietitian if adherence is questionable. NIH says they should refer to a knowledgeable dietitian, and the American College of Gastroenterology also says refer to a knowledgeable dietitian. But no one in here is really focusing on the education part, where we're really looking at guiding our patients to navigate that daily life, avoiding chance exposure, but also navigating to a healthier intake within the gluten-free parameters. The guidelines currently focus on assessing adherence or referring when a problem arises, but not the usual course of care. So what should we do? What is the standard? We know that they recommend a dietary evaluation, but as we started digging deeper, we realized even in a small project that we were doing in a multi-center study in the US between Boston, Chicago, Vanderbilt, and Columbia, that in these 4 major centers, no one was using the same tools for education or assessment or monitoring adherence. And we found that there was great variation in what was included in a standard nutrition visit for a patient with celiac disease. There was no consensus on the amount of time spent, how frequently someone was followed, what was included in the visit, or even, big topics like chance exposure, inclusion of oats. There was no standardization at all. So with that, we looked at it and said, we need to look at we need to look at how we do this. And before we can really say that we can best help our patient navigate the daily life and enhance their nutritional intake, we need to have a standard. And so we started the nutritional assessment project. And the importance of this project is really to shape the future of dietary intervention and really have a standard of care that matters. And we want to establish uniform guidelines, standardized content, so that no matter where our patient is being educated on the gluten-free diet, that they are indeed getting the same information if they're in Chicago, New Delhi, or Oslo, that we really want this to be something important. And we want to make sure that we provided good educational materials. And this was all part of our initial GluTech study. That's an NIH study we're doing and with Dr. Lebwall. So more than just a project, we really said, this is an opportunity to really build the future. And we looked at the current practice, realized there's no consensus. So with a work group from the 4 different centers, we started doing literature review, really said we need to develop a template for an inclusive nutritional assessment that included clinical markers, physical activity, symptoms, intake. We also, besides that, realized we needed to standardize an adherence tool. Right now, there are several tools out there, but there's no consensus as to which one to use. In looking at our lit review, we found several studies used 2 or 3 and kind of picked one as results. So we're working on developing a new adherence tool as well. It's an RD-focused group that developed it. It was trialed in clinical use, reviewed by experts from outside sites, and we're working on some of the psychometric analysis and making it culturally diverse and acceptable. So this project sounds wonderful in theory, but we did it. So what we did is we had a team of dietitians, Melinda, Lori Westhub, Jessica Leibowitz, and Joanna Pearl. And we did an intensive targeted lit review. We then developed review questions. We came up with comments, additions, and edits. We had a consensus between the 4 sites. And then we had external reviewers look at that and give their comments and edits. And then we went through another round of questions, comments, and edits. There was a lot of discussion, a lot of back and forth on trying to really figure out what is the best knowledge, what is the most common knowledge, and how can we best serve our patients to make sure that they're getting the nutritional information to choose a nutrient-based gluten-free diet, but also the guidance on how to do it and navigate, real life. So it was a lot of teamwork. We met monthly, starting in the fall of 2021. And as we said, formulated the list of topics, identifying not just concerns from an assessment and clinical point of view, but looking at barriers to adherence, concerns patients voiced, making sure that there was within the education definitions and descriptions of what celiac disease is, what's the pathophysiology, how does it affect you, why does that then make a difference? And we really want to focus on how much diet matters. And so we group topics by common threads, and then each dietitian group with their GI leaders went through, again, all the information and really dove down. And we came up with a final draft. We had the external reviewers incorporate that, and we developed a white paper that is published, I believe, this week. It's like on the cusp in the Journal of Human Nutrition and Dietetics. And it outlines the guidelines for standard nutritional assessment. It's a draft of a new tool, and it also had guidance on what the hot topics are in terms of inclusion in the gluten-free diet, and really making sure that we talk about chance exposure. What are the myths versus the reality? Are we making our recommendations based on science, not on hearsay? And so that's what this paper has proposed. But our work is not done. We realize that that's great if we have assessment and standardization here in the US, but we need to formulate it on an international basis. We have dietitians recruited from across the globe, Europe, India, China, Argentina, Canada, Greece, just to name a few. And we're looking to standardize nutrition therapy for celiac disease, including a standardized assessment, standardized education, and standardized monitoring and adherence. So as always, any of these projects take a village. So I thank you to my team for making it happen, and to all of you for listening and your interest.
Thank you, Anne, for a terrific way to sort of set the table at the beginning of this day-long course. Just as a reminder, for those of you who have questions, we're going to be doing a question and answer session at the end of this morning's session. And so please put your questions in now so that we can take a look and be ready so that we can have a lively discussion. We'll now move on to our next speaker, who is Dr. Maureen Leonard. Dr. Leonard is the clinical director of the Center for Celiac Research and Treatment at Mass General Hospital for Children, and an assistant professor of pediatrics at Harvard Medical School. Dr. Leonard will be speaking on a topic of healing on the gluten-free diet in adults and children.
There we go. Thank you so much. Good morning, everybody, and thank you for inviting me to speak about mucosal recovery on the gluten-free diet. I have a few disclosures, but they aren't related to what I'll be talking about today, because today I'll be really talking about following up and monitoring recommendations for patients with celiac disease. I'll be discussing mucosal recovery in patients with celiac disease, and then describing non-responsive celiac disease as well as treatment options. Okay. So I think we can all agree that both mucosal recovery and symptom resolution are goals of celiac disease treatment. A strict adherence to a lifelong gluten-free diet is the only effective and available treatment for celiac disease. And again, mucosal recovery is really one of the main goals of celiac disease management. And yet there are no guidelines for routine follow-up endoscopy with biopsy to assess the mucosa. So current management guidelines suggest repeating diagnostic serologic studies every 6 months until they normalize, and then yearly. But studies show that serology really isn't predictive of adherence to the gluten-free diet or to mucosal recovery. So what are the recommendations to follow patients with celiac disease? This is a figure that I altered from a recent review by Dr. Tai Din, and then I modified it to include children based on some pediatric European and North American guidelines. And then for the purpose of this talk, I'm going to sort of skip over what we do at diagnosis and focus on the time period following diagnosis. So patients with celiac disease are recommended to be seen by a physician and dietitian 3 to 6 months after diagnosis, and then every 6 months until TTG levels normalize and they're feeling better. So at the time of these additional follow-up visits at 6 and 12 months, one should discuss mental health, signs and symptoms, especially growth in children. We can repeat celiac serology and any abnormal labs. And then dietary adherence should be measured by a dietitian, questionnaires, and then a combination of symptoms and labs as well. Once TTG is normalized and patients are feeling better, they should be followed yearly by a physician and dietitian. And again, the same assessments regarding signs and symptoms, mental health, growth, laboratory studies are all repeated. And then at 1 year after diagnosis and beyond that, there should be consideration of a repeat duodenal biopsy in certain cases. So either when patients aren't responding to treatment, or there are new symptoms, a suspicion of a new condition, or maybe even due to patient preference. And while that's a very helpful roadmap to follow and sort of how we should follow patients with celiac disease, we still have this major issue in that we don't have a really accurate non-invasive biomarker to follow patients with celiac disease. So we use sort of a combination of markers. So we assess symptoms, but we know that up to 30% of patients may be asymptomatic at diagnosis. And then we and others have shown that symptoms don't correlate with mucosal damage. We have dietary assessment and questionnaire. So you heard about the amazing work that Anne and colleagues are doing. So hopefully that will be a big change. But right now, until we see that paper, it can be hard to really tease out exposures. So we can also use gluten immunogenic peptides. These are tests that we can do in the urine or the stool to look for gluten exposure. We're using these in clinical trials. It's being used more in practice, but right now it's not covered by insurance or offered by hospitals. So it's something that patients need to do on their own, and it's costly. So again, guidelines suggest we follow serology, and while positive studies might be suggestive of gluten exposure, numerous studies suggest that negative tests are not predictive of adherence to the gluten-free diet or mucosal recovery. So we have an objective biomarker, which is duodenal biopsy, but it's invasive and it has its own issues. It's not perfect. There can be sampling errors. There can be errors in orienting the tissue. And then we don't have full yet agreement, I don't think, on what defines mucosal recovery. So there's some discussions around, should we be calling it mucosal recovery, mucosal activity, mucosal healing, celiac disease in remission, and how do we define all this? That's something that we continue to work on. But for this talk, when I refer to mucosal recovery or persistent enteropathy, we'll define it according to the Marsh criteria, which you can see here, which evaluates the histology for intraepithelial lymphocytes, crypt hyperplasia, and villus atrophy. So mucosal recovery here is going to be defined as normal histopathology, so Marsh 0, or an increase in intraepithelial lymphocytes, Marsh 1. Persistent enteropathy is defined mostly by Marsh 3, so still having persistent villus blunting, or Marsh 2, which is an increase in intraepithelial lymphocytes and some crypt hyperplasia. So when do we expect improvement in signs and symptoms and biomarkers? So we might not have enough data to know for sure regarding histology, but we do know that symptoms and biomarkers usually recover in different time frames, with symptoms taking weeks or months, so resolving more quickly compared to histologic changes which are expected to take closer to 1 year or more. And we're defining mucosal recovery and persistent enteropathy according to histological findings and Marsh criteria. But there's been some work looking at if we can use some of these non-invasive methods to predict villus atrophy. And I've mentioned the guidelines suggest to follow serology, but these markers have sort of poor sensitivity for picking up people that have a persistent villus atrophy and for patients that need sort of additional treatment. You can see that here. And then studies show, of course, dietitian evaluation is valuable, and we do need validated adherence scores, but the ones that we've had so far have sort of a lower sensitivity. So again, not sensitive enough to pick up these patients that have persistent villus atrophy and might need additional treatment. So the role of duodenal biopsy in the follow-up care of patients with celiac disease is controversial. Routine follow-up biopsies are not suggested for all patients in any of the management guidelines. There were some recent guidelines published in Nature Reviews for adult patients, and they suggest that some patients should have a follow-up biopsy, and those include patients with persistent signs and symptoms, and I would add to that children that are having slow growth that haven't responded to the gluten-free diet should be included there. Patients that have red flags and symptoms, so patients with diarrhea, weight loss, and malabsorption. Patients that have development of or persistent hematologic deficiencies, so those patients whose anemia is not getting better, they may have other nutritional deficiencies. Patients with persistently positive TTG, despite having reviewed their diet with a dietitian. And then they leave room for patient choice or preference. So if patients want to ensure they have healing after starting on that gluten-free diet or have other concerns, then we can consider a repeat biopsy. And then for those undergoing a repeat biopsy, how should we assess their mucosal activity? There are guidelines around what we should be doing when we're diagnosing celiac disease, but how about these follow-up biopsies? So studies suggest the ideal timing of a repeat biopsy is about 1 to 2 years after diagnosis, again, unless there are concerning signs or symptoms that prompt an earlier diagnosis. Like at diagnosis, biopsies should be obtained from the bulb and the second portion of the duodenum. Ideally, the GI doctor would take 1 biopsy per pass of the forceps to make sure that the biopsy stays intact. And then there are other methodologies we can use while we're in the endoscopy to ensure that we're collecting samples from areas that look to have damage, since we know that celiac disease can be patchy both at diagnosis and follow-up. But again, we don't have an accurate biomarker right now for follow-up, and that's important because we know that the gluten-free diet is very difficult to follow. And while the majority of patients do get better on a gluten-free diet, not all do. And so there are some patients that have non-responsive celiac disease, which is defined as persistent symptoms and/or enteropathy despite 6 to 12 months on a gluten-free diet. And data suggests that in adults, up to 30% might have persistent symptoms despite being on a gluten-free diet, and more than 40% can have persistent villus blunting or persistent enteropathy despite 2 years of treatment on the gluten-free diet. And there are some complications that have been associated with persistent villus atrophy or persistent enteropathy. These include nutritional deficiencies, osteoporosis, and an increased risk of hip fracture, and then rarely lymphoproliferative malignancy or cancer. So in children, the definition is the same. So children can also have non-responsive celiac disease. We think it's less common, but we have more limited data as well. So one study suggested that about 15% of children on a gluten-free diet may have persistent symptoms after about 2 years on a gluten-free diet. And that up to 19% can have persistent enteropathy again after 2 years on a gluten-free diet. And we don't know the consequences of this in children. It's possible that, or if there are consequences, but if there are, it's possible that they might be similar to children with undiagnosed celiac disease. So issues related to growth or nutritional deficiencies like we see in adults. They may have altered school performance, and we are concerned about other things like dental enamel defects. So these are possibilities, and we need additional studies to look at this. We have some new data currently under review. So this is some work led by Dr. Dennis Chang at Boston Children's, and he looked at 8 pediatric centers from the US and Canada. And what we did in this work was looked at 130 children with celiac disease on a gluten-free diet who had a repeat biopsy within 15 months of starting their gluten-free diet. And our goal was to try to begin to understand the natural history of mucosal recovery. And in this work, we found that about 74% of children who underwent at least 1 endoscopy in the first 15 months after adopting a gluten-free diet had mucosal recovery. And 48% of those who had a repeat endoscopy less than 3 months after starting the gluten-free diet had mucosal recovery. And overall, in total, 26% had persistent enteropathy. What we also found was that a greater proportion of children with persistent enteropathy had poor weight gain, or weight loss, and joint-related complaints on initial presentation compared to those with persistent enteropathy. So this was just starting to look at what's that early kind of time period after a gluten-free diet, and can we start to understand how children, the natural history of mucosal recovery in children. And when we look at kind of our recent data in another way, when we look at these 130 children in another way, we can see that about 60% had mucosal recovery after 6 months on a gluten-free diet, and 81% had mucosal recovery after a year on a gluten-free diet. And comparing that to another study that was in adults, we can see that adults seem to have about 53 to 68% of adults had healing in the same time period, so within a year. suggesting that children heal earlier or faster, and that overall more children have mucosal recovery compared to adults. And these findings are similar to another recent study published earlier this year, where gastrointestinal pathologists from 13 different centers evaluated collected pairs of initial and follow-up biopsies from patients with celiac disease. And then they tried to correlate the pathology findings with some clinical markers, so TTG, symptoms, age, and gluten-free diet adherence. So this was a study that occurred, and they looked at both children and adults. And the mean time from starting a gluten-free diet to the second biopsy was about 3.3 years. Then there was a range of 1 to 18 years, so a much larger range than the other studies that we just looked at. And again, their goals were to look at the prevalence of persistent enteropathy and then determine whether there were clinical factors that could reliably predict mucosal recovery or persistent injury. And then I just have two figures. This is the Marsh score from 0 to 3, and the number of intraepithelial lymphocytes in children and adults from this study. And here again, what they found was persistent enteropathy was common, so it was about 31% in this study. Children were more likely to show normalization of Marsh score and intraepithelial lymphocyte counts compared to adults. So again, seemed to heal more completely and faster. And again, they also found, like other studies, that serology, symptoms, gluten-free diet adherence, none of these things could predict mucosal activity status. So what do we know about risk factors for persistent enteropathy? Currently, we know for adults, factors such as having severe disease at diagnosis, poor adherence to a gluten-free diet, those who had a repeat biopsy sooner after diagnosis, they have a risk of persistent enteropathy. Other factors in adults include lower educational status, having weight loss, and then being on medications including PPI, NSAIDs, and SSRI. For children, we don't know what the risk factors are for persistent enteropathy. Again, in the study that we, Dr. Changlang, that's under review, for weight gain or weight loss and joint complaints at initial diagnosis were all linked to persistent enteropathy, but we need more data. What multiple studies have shown, again, is that symptoms and negative serology are not predictive of enteropathy in children or adults. So just briefly, how do we evaluate and manage these patients who don't have mucosal recovery or who have non-responsive celiac disease? And evaluating the initial diagnosis is always the first step. So we want to make sure that these patients have a confirmed diagnosis of celiac disease by reviewing the initial serology and histology. And if they don't have a confirmed diagnosis, then we would suggest doing a gluten challenge. Definitely having a patient meet with a dietitian is the most important thing we can do. They need to review the gluten-free diet, see if there's any gluten getting into the diet. Other things we can do are to do the gluten immunogenic peptide testing. And then we want to talk about barriers to adherence as well. So sometimes for children obtaining school lunch or young adults who are at college without access to a kitchen, they might have a particular difficulty in maintaining a gluten-free diet. Other adults have other issues as well, so there can be barriers just to maintaining a gluten-free diet that we need to discuss. If we haven't found anything there, then we consider other medical etiologies. So could there be symptoms due to lactose intolerance, constipation, irritable bowel syndrome? And then once we have considered those as well, we would consider repeating an endoscopy, colonoscopy, and possibly a video capsule endoscopy if needed to really assess and see whether celiac disease could still be active, whether we have mucosal recovery or not. So there are some treatment options if a patient has non-responsive celiac disease or persistent enteropathy now. There's something called the gluten contamination elimination diet, which I think is used very sparingly and probably used less than it was a couple of years ago. It's very restrictive, so this has to be done with the help of a dietitian who's closely monitoring the patient. And this diet essentially removes all processed foods and leaves in just fresh fruits and vegetables and proteins. The other option that I think we use more commonly is using budesonide for about a 3-month course. And there's a protocol by the Mayo Group that is used and has a great response for patients that have persistent villus enteropathy and have persistent symptoms. So in thinking about some of the differences between children and adults, we know that there are some differences in symptoms and there are some differences in mucosal recovery as well. Right now, we don't really have the data, but we assume that most children that are diagnosed quite young heal. And then when we get into the school-age children and adolescents, the data so far suggests that about 75 to 80% will have mucosal recovery after 1 to 2 years on a gluten-free diet. And this is compared to adults where we think somewhere between 60 to 70% would have healing or mucosal recovery on a gluten-free diet. So we definitely need more research to understand the natural history of mucosal recovery and the frequency of persistent enteropathy. Clinically, we need to work on improving our follow-up care and develop more accurate biomarkers to follow disease. We need research in this area and looking at other ways to evaluate the intestinal mucosa or maybe getting more out of the biopsies that we're taking. We need to define healing sort of as the community. So are we looking for normal tissue or an improvement since the diagnostic scope? Are we taking the worst section, the best, or an average? And are we looking at the bulb or the second portion? Does where the disease persists matter? And finally, we need to inform patients and other practitioners. So there are going to be more treatment options. There are some right now, and there will be more in the pipeline. So having confirmed diagnosis of celiac disease matters. So we can access medications when approved, and follow-up matters because we'll have hopefully more options to assess and manage disease. So in summary, we still have a lot of work to do to understand the natural history of mucosal recovery. Biomarkers of mucosal recovery are needed. And when somebody is not feeling well, we should take a systematic approach to evaluating why they may have persistent symptoms. Follow-up care right now is inconsistent, but hopefully that'll change as more biomarkers and treatments become available. And adjunctive therapies for celiac disease are under development. We'll hear more about that later today. So we need to understand the extent to which those are needed, both in adults and children. Thank you.
Thank you so much, Dr. Leonard. Awesome, as always. Really a nice, very comprehensive review with both adults and children. And I just want to remind everyone, please, Q&A, please put in your questions in that. We would love to have questions from the audience. I know that I'm sure Ben and I have some questions for you that's going to come up later, but thank you very much. And now we'll move on to our team from Colorado. So we have our next, there's going to be 3 people that are going to go. And as you know, earlier Anne mentioned, it's always a group effort here taking care of children with celiac disease and adults. But leading the team, we have Dr. Stahl. She is the research director of the Colorado Center for Celiac Disease. And along with her, we have Sadie Nagel, who's their dietitian, our dietitian. And also Dr. Germone, who is our psychologist, who will be joining as well. So team effort, and we're going to talk about the gluten-free diet in different age groups. Dr. Stahl and group, take it away.
Thank you so much to the organizers of the symposium for inviting us to speak. I'm Marisa Stahl. I'm one of the pediatric gastroenterologists at the Colorado Center for Celiac Disease, and I'm joined by our dietitian, Sadie Nagel, and our psychologist, Dr. Monique Germone. And we're going to give a high-level summary today of how we approach the gluten-free diet in different pediatric age groups at our center. Next slide, please. So here are our disclosures, none of which are related to the talk we will be giving today. Next slide. In this talk, I will review the medical aspects, Sadie Nagel will review the nutritional aspects, and Dr. Germone will review the psychosocial aspects of the gluten-free diet for celiac disease throughout childhood. So first, the medical aspects. Next slide. So I'm going to focus on these concerns that come across in all age ranges today, but there may be some variability in the approach based on the child's age for monitoring. And the first is growth. The second is concurrent autoimmune disease. And finally, we'll talk about gluten challenge in different age groups. Next slide. So throughout our talk, we're going to discuss the approach in these different age ranges, including infancy and toddlerhood, preschool years, school age, and adolescence. So normally for growth in infancy, we see very rapid growth, particularly with respect to weight. And an infant's height curve often crosses percentile lines during the first 24 months of life, as growth moves more away from the influences of the intrauterine environment towards the child's genetic potential. So once the child gets to that 2-year mark, their height at 2 years is going to correlate much more with what we expect their adult height to be. In preschool and pre-puberty, there's a pretty relatively constant growth velocity. And then you have puberty, which is characterized by this growth spurt that can begin as early as 8 for girls and as early as 10 for boys. And then after puberty, children have generally reached their adult height. So when we're talking about celiac disease and monitoring growth, we really want to intervene by that time point of puberty so that we can catch up for their adult height. So we'll discuss more about the implications of this for growth monitoring in celiac disease on the next slide. With respect to concurrent autoimmune disease, once you are diagnosed with celiac disease, you are at increased risk of concurrent autoimmune diseases throughout the lifespan. And there is not necessarily great evidence that breaks this down by age specific to celiac disease, but this slide just shows kind of my general gestalt on this. So in general, type 1 diabetes, and we'll show more slides on this later, tends to develop earlier in childhood, whereas autoimmune thyroid disease and autoimmune liver disease, we may see later. Next slide. So a little bit more on growth on a gluten-free diet. In general, weight recovery tends to be much, much more rapid than growth recovery. And interestingly, those with short stature tend to present later in life. One study showed that the age at presentation when kids come in with short stature is more likely to be school age to adolescence. And there actually are some guidelines from ESPGHAN that offer suggestions for what to do for the follow-up of children with celiac disease on a gluten-free diet. And they suggest that improvement in growth is typically seen within 6 months. And they actually recommend an endocrine referral if there is no significant catch-up growth within a year. And that's regardless of age. My own clinical experience is that this catch-up growth can be incredibly variable. Some children take years and some children recover really, really quickly. So my urgency for an endocrine referral is really guided by the child's proximity to puberty for the reasons that we were talking about earlier. We want to catch the child before they go through that pubertal growth spurt so that we can help them catch up to their projected adult height. And so the closer they are to puberty, the more urgent the referral to endocrine is because there's less of that timeline to intervene. And for growth hormone deficiency, really the outcomes are better with earlier treatment, and children with celiac disease can have concurrent growth hormone deficiency. So especially if a child is getting close to that pubertal growth spurt, I will talk to the endocrinologists who work with us at our center, and to help expedite that workup, I'll often consider sending a bone age, an IGF-1, and IGF-BP3. Next slide. So what about concurrent autoimmune disease on a gluten-free diet? Well, there's thought to be some protection from concurrent autoimmune disease once a child is on a gluten-free diet. However, it's also important to keep in mind that a younger age at diagnosis is also a risk factor for concurrent autoimmune diseases. Type 1 diabetes and autoimmune thyroid disease are the most common concurrent autoimmune disorders in the pediatric population. But with that said, there are also other autoimmune diseases that we can see. And there are currently no formal recommendations for islet autoimmunity screening, although I think the landscape of that is really changing as they're developing more interventions to help delay progression to clinical type 1 diabetes. And for those who are interested in learning more about screening for type 1 diabetes, Ask Health and Stop T1D are great resources for the interested provider. We also screen for thyroid disease and autoimmune liver disease with our healthcare maintenance labs, as was outlined in the last talk by Dr. Leonard. Next slide, please. So just a little bit more on islet autoimmunity and type 1 diabetes. So islet autoimmunity is what we see prior to the progression to clinical type 1 diabetes. And islet autoantibodies, IAA, GATA, IA2, and ZNT8 are what we screen for, and they appear very early in life, starting at 6 to 9 months of age, with the incidence peaking at 1 to 2 years of age, as you can see in the figure on this slide, and then rapidly decreasing by age 4 to a steady rate until puberty. And so, like I said, there are no formal recommendations for screening children with celiac disease, but in general, based on this incidence curve, what has been recommended by other experts is screening at least at the age of 1 to 3 years old, and then again at 4 to 6 years of age, and then again at 9 to 11 years of age to detect 90% of children who will develop clinical type 1 diabetes by age 15. It's also interesting, there's literature from the TEDdy study, which studies children at genetic risk for type 1 diabetes and celiac disease, that suggests that islet autoimmunity most commonly precedes celiac disease autoimmunity, although this is not always the case. So it is still important to think about this when we're seeing children with celiac disease in follow-up. And so how common is it? Well, there's a recent study from Italy that looked at islet autoimmunity for children with celiac disease that showed a prevalence of 5.5%, which is over 2 times the prevalence that has been observed in the general population. So definitely something we should be thinking about for children with celiac disease when we're seeing them in follow-up. Next slide. So what about autoimmune thyroid disease? So this is also very common in children with celiac disease. Some studies report up to 10.5% prevalence of autoimmune thyroid disease in celiac patients. But this happens later than typically what we think of for type 1 diabetes. So one study showed an average age of onset in the pediatric population around 10.5 years old. And similar to diabetes, there isn't a ton of guidance in terms of what we should be doing for monitoring, and it's not necessarily guided by age. But there are recommendations to check a TSH at least at diagnosis, and there are not recommendations for follow-up and frequency, although at our center, we're checking every time we send those healthcare maintenance labs. Next slide. So what about other autoimmune diseases? So there is a significant association with many other autoimmune diseases in adolescence: arthritis, psoriasis, and then autoimmune liver disease, particularly autoimmune hepatitis or AIH, where there's a noted prevalence of about 4 to 6.4%. With that said, celiac hepatitis is by far the most common thing that we see at presentation, and that will resolve in about 75 to 95% of patients who go on a gluten-free diet. So with that in mind, we should follow any abnormal liver testing at diagnosis. And similar to the other autoimmune diseases that we've been talking about, there isn't really guidance for routine screening for the development of liver disease. So we will screen with an AST and ALT with our healthcare maintenance labs, regardless of age. Next slide. Okay, so the final thing I'm going to talk about with respect to medical aspects is the gluten challenge. So for children on a gluten-free diet, there may be times where a gluten challenge is warranted to help with diagnostic confirmation. For the primary care providers on the front line who are listening in now and helping patients when they get a positive test result, I just want to emphasize that it really is easiest to stay on a gluten-containing diet until the diagnosis is solidified with a gastroenterologist. But with that said, sometimes a gluten challenge is necessary when we are seeing these patients in GI to get clarification for a new diagnosis, whether gluten is causing symptoms, or if the patient has a history of a potential or an unknown diagnosis. And some of what we do with respect to gluten challenge and how we counsel patients may be based on the age of the child. So what a gluten challenge entails is a minimum of 3 to 6 grams of gluten per day for 12 weeks, which, as you can imagine, if the question is gluten causing symptoms, that can be really, really hard for a child to complete a full 12 weeks. Previous guidelines recommended not undergoing a gluten challenge before age 5, but now guidance really says that there's no age or stage that is absolutely contraindicated. Similar to what I was talking about for growth, we really take into account how that child is presenting and what the clinical concerns are. So I typically, will not do a gluten challenge if we're concerned about short stature and we're just starting to see catch-up growth, and there's a question of the diagnosis. Well, then I may wait until after puberty, actually, until we've really, we're not concerned about growth anymore. Or, for example, if a child was recently diagnosed with autoimmune thyroid disease, that may not be the time to undergo a gluten challenge to help clarify the diagnosis. So not necessarily based on age or stage, but on the clinical presentation of the child. Next slide, please.
Thank you, Dr. Stahl. Next slide, please. With each age group, macro and micronutrient needs do vary pretty greatly. With regards to celiac disease, it's incredibly important to ensure that these needs are being met through a gluten-free diet that ensures nutrient dense through the incorporation of a variety of fruits, vegetables, naturally gluten-free whole grains, as well as protein sources. Working with a registered dietitian to ensure adequacy cannot be stressed enough when it comes to pediatric celiac disease. Next slide, please. There is evidence to show that the gluten-free diet comes with some benefits as it relates to pediatric celiac disease. In particular, when we think about how adolescence is where half of adult bone mass is obtained, the gluten-free diet has been associated with higher bone mineral content as well as density in the pediatric population. Children have also been shown to achieve full bone health recovery within the first 2 to 3 years of being on a strict gluten-free diet. And we see normalization of BMI in children who were categorized as underweight at the time of their diagnosis. And when we think about the incorporation of a variety of complex carbohydrates through gluten-free whole grains as well as pseudo cereals, we can achieve improved intake of iron, calcium, fiber, magnesium, as well as folate. Next slide, please. The gluten-free diet, though, isn't necessarily more nutritious. Gluten-free food products have been shown to be higher in calories, fat, and sodium composition. With consideration of the global trend in BMI, it is important to monitor growth, as rapid weight gain can affect growth patterns, bone maturation, as well as puberty. While a strict gluten-free diet can allow for intestinal restoration of absorptive function, long-term, the gluten-free diet may not necessarily prevent other nutrient deficiencies from occurring due to low micronutrient content as well as intake, with the reliance on processed packaged gluten-free food products. A 10-year follow-up study of pediatric patients in the Netherlands actually showed that vitamin D and iron deficiencies were still quite common, even at the 10-year mark. And B12 and folate and zinc deficiencies were still present up to 5 years out from starting a strict gluten-free diet. For pediatrics, ensuring nutritional value on a gluten-free diet throughout childhood is absolutely essential to ensure normal growth as well as development. Next slide, please. So putting that all together, when assessing a pediatric patient of celiac disease, it's important to remember that the gluten-free diet is low in iron, B vitamins, calcium, zinc, as well as magnesium. As Anne already mentioned, the FDA does enrich wheat products back to its natural nutrient content, which is inherently rich in fiber, iron, and B vitamins. And gluten-free foods are not required to be enriched or fortified. And for some children leading into this diagnosis, these foods have actually been their major sources of some micronutrients. It's important to consider concurrent dietary restrictions that may exacerbate the risk of deficiencies, such as them also following a vegan or vegetarian diet or having other food allergies in consideration with celiac. At follow-up, it's very important to assess that nutrient value of the diet and consider long-term follow-up of micronutrient labs with specific supplementation as needed. And if the diet is really ultimately lacking in variety, pardon me, as well as adequacy, recommend a complete multivitamin to ensure that all RDIs are actually being met. Now I'll pass it over to Dr. Monique Germoni to discuss psychosocial aspects of the gluten-free diet.
Thank you, Sadie. My name is Monique Germoni, and I'm the pediatric psychologist with the celiac team, and I have the pleasure of reviewing psychosocial aspects of celiac disease across the pediatric developmental spectrum. One of the most important points of our talk today has been considering the child's development across stages and phases. Today, you will hear that this is especially relevant to psychosocial impact. Here I have summarized the key impacts of celiac disease in each developmental stage. Let's go into them more deeply now. We will cover what's in the literature and what is available to support children across the developmental spectrum. We will start with infancy and preschool together, also known as early childhood. I was curious what our literature had to say about these particular developmental groups. And over the past 10 years, very few studies have focused specifically on this grouping. Those that had, according to my rough PubMed search, focused solely on medical factors and mostly on prevention of the condition. This is not surprising, and while all of these topics are important to this age group, I placed this chart here to hopefully also inspire others to consider if additional topics should be further studied, including psychosocial impact. Anecdotally and based upon clinical experience, we know that this condition is not without psychosocial impact at this stage. I would argue that most of the impact is on caregivers, the adults who care for these children. A recent review in 2020 by Rosie Satherley, Shayna Coburn, and myself investigated just this presumption. What we found in our review of both qualitative and quantitative studies was that caregivers are experiencing distress and concern for their child. This condition also had ramifications that impacted their families. With this in mind, I created a health behavior intervention to support caregivers of young children with celiac disease. I received funding to pilot this intervention from the Society of Pediatric Psychology and the American Psychological Foundation. Our study is just wrapping up, but I'm excited to share some preliminary results. So far, the intervention has been feasible, with all participants completing at least 1 to 2 intervention sessions. The intervention was acceptable to families, with 94% saying that they found it an acceptable treatment to help their child with the gluten-free diet. All families were satisfied with the intervention, and preliminary findings on adherence scores from Sadie, our dietitian, demonstrated 94% had good to excellent adherence. But most importantly is what many caregivers provided in their qualitative feedback, similar to this quote. A major function of the intervention served to provide social support to the family to help them adjust and support their child. Put together, supports for young children should include a focus on caregivers. Let's move now to our school-aged children. This is our biggest group, both clinically and in the literature. A variety of topics are covered in the literature, according again to my rough PubMed search over the past 2 years. Most prominent topics included guidelines and reviews, screening and diagnosis, comorbidities, and prevention of celiac disease. Of note, psychosocial topics emerge here, including a focus on quality of life, school, mental health, and skill development, just to name a few. While a focus on the school setting is an emerging topic from the rough literature search, anecdotally, we know that school is a major portion of a school-age child's life. Accommodations can be very helpful in this setting. Resources do exist to help families navigate the laws and ways to advocate for their child in the school setting, including these resources from the Celiac Disease Foundation. Additionally, social connection is of growing importance and influence in school-aged children. 2 studies have been conducted looking at the impact of celiac camp on children with celiac disease. The first was in 2010 using prospective survey data of children who participated in a summer camp in California. It was found that camp did have a positive impact on all campers, but most particularly on newly diagnosed campers within the past 4 years. The second study was in 2022 in Germany using a retrospective survey asking individuals with celiac disease to reflect on their prior celiac camp experiences. Individuals who had attended camp tended to have higher celiac-specific quality of life scores, so indicating good quality of life, which appeared to be mediated by having more friends with celiac and perceiving higher social supports. These individuals also reported lower anxiety symptoms and higher levels of acceptance of their condition. These results give evidence to suggest social connection, and in this case, through celiac camps, may be a beneficial referral for children with celiac disease. And lastly, we move to adolescents. Much of the research in this area is subsumed within the research on school-aged children. Given their unique developmental needs, it becomes a consideration that more research is needed in this area of development. Of the 10 studies in the past 5 years that I found, a large portion focused on adherence. This is not surprising, given that many adolescents do struggle with following the gluten-free diet. Despite this struggle, I will highlight now the work by a few of my colleagues to help support adolescents. The first is work from Dr. Sonia Meyer. Dr. Meyer developed an app concept to help identify ways to navigate the most common situations encountered by adolescents with celiac disease. The top 3 seen here in this photo are eating out with friends, eating a meal on a family vacation, and eating a meal on a school field trip. An in-depth review of the app is outside the scope of today's presentation, but here you have an overview of the action categories that the app walks adolescents through to help know what steps can be taken to ensure safe risks when dining out. The app, unfortunately, is not available for wide distribution, but this concept helps highlight the multiple steps needed to become self-sufficient in managing the gluten-free diet. Next, Dr. Meyer has developed a self-management questionnaire called the CD chart, with a goal to help identify the child or adolescent's strengths and weaknesses related to their own goals of managing their gluten-free diet. The questionnaire covers 9 main areas, ranging from navigating meals at home, on vacation, with extended family, friends, and when at camp or school. Lastly, Dr. Meyer conducted qualitative analyses of child and adolescent self-reports on what steps and activities are needed to manage their gluten-free diet. There were over 125 different steps and activities identified and were categorized into 9 different categories here. This demonstrates the complexity of managing the gluten-free diet and is not as simple as just, quote, go gluten-free, which is why this warrants more research and intervention. Dr. Rosie Satherley has developed a self-help guide that reviews educational topics on what celiac disease is and how to navigate a gluten-free diet, as well as cognitive and behavioral tips to navigate the feelings of isolation and worry that can come from having a chronic medical condition and following a restrictive diet. You can follow a link here to review the guide. Dr. Satherley is currently conducting a randomized control trial to evaluate the guide. She shared with me promising preliminary results of completing full recruitment within 24 hours. She has over 100 people that she was able to get within 24 hours, a big achievement, which demonstrates the strong desire and need for this type of support. Lastly, the latest project from Dr. Shana Coburn. Dr. Coburn is currently completing a trial of her cognitive behavioral skills group for adolescents with celiac disease. The group is virtual over the course of 6 weeks and includes a component for the adolescent and their parent. Dr. Coburn also has had positive preliminary results with high intervention completion rates, definitely demonstrating the need for these supports. Returning to our developmental stages, across each stage, there are unique needs for support, whether that is for caregivers, the community, and the child themselves. More work should continue in these areas, to establish empirically supported treatments to navigate the unique settings and situations these children find themselves in. As a medical community, one can continue to keep these psychosocial aspects in mind and ask caregivers how they, their child, and their family are doing. To support the child and family, helping to identify their strengths can help families to know what to continue to do and provide them with necessary feedback regarding their own competence. Lastly, there will be times when more support is needed and a referral can be made. When referring to more help, there are many local resources which are outside of the scope of today's presentation. However, I have highlighted a couple of lesser known and celiac specific resources that may be of help. Firstly, there is a Psychosocial Health CE self-guided webinar that reviews celiac disease and provides an overview on identifying and treating psychosocial needs. Please follow the link here to learn more. And lastly, consider the resources and potential benefits of joining a community of providers and researchers focused on behavioral health and celiac disease. This is a volunteer-led organization and all resources and benefits are free. Please follow the link here to learn more. Thank you for your time today, and a big thank you to our team and the families we serve at the Colorado Center for Celiac Disease.
Thank you to the team from Colorado for a really enlightening presentation. Lots to think about and lots to discuss, so please use the Q&A so that we can incorporate the Colorado team during that session as we wrap up this morning. We would now like to introduce Lori Wellstead, who is a licensed dietitian and nutritionist at the University of Chicago Medicine Celiac Disease Center. She specializes in outpatient nutrition counseling and education for adults with GI conditions. Although Lori can't be with us today live, she has recorded her talk, and she'll be presenting on the topic of the challenge of living a gluten-free diet in the adult world.
Hello, it's an honor to be here today. I will be discussing in my 20 minutes the challenge of living a gluten-free diet in the adult world. And I am the adult registered dietitian here at the University of Chicago Medicine. Thank you again. So today we're going to be talking about some of the concerns and considerations for those embarking on a gluten-free diet, social concerns, and those with celiac disease. We'll be reviewing some of the different living situations and what to consider in those environments, as well as some of the different considerations for traveling. And then lastly, hope you'll have some realistic tools to take away to utilize to help with adherence for those patients that are following a gluten-free diet. So there are a variety of challenges that someone with celiac disease encounters at the time of diagnosis. Oftentimes they are initially shocked at the diagnosis. They have lived their entire lives up until this point consuming gluten. Many need to really mourn the loss of gluten in their lives. It's like a close family or a friend that has passed away, right? So I often compare it to that they have to mourn the loss of that gluten that they really have been consuming, like I said, their entire life. And it really encompasses so many different aspects of their life. And really start to find some different kind of coping skills and mechanisms to help them in their day-to-day to ensure that they have some safe options and to ensure they're not, walking around just being very hungry or hangry. Many individuals are very overwhelmed as this is something that, is not a quick fix kind of a diet. This is something that they will have to be on lifelong. And so often this is something that takes time for someone to really adhere to those changes. And then lastly, with that shock, despite many really good intentions and best intentions of our patients, many continue to get gluten eating out, and despite really their best intentions. So really working through some of these challenges that they are facing on a daily basis. Quality of life is dramatically decreased in those individuals with celiac disease, and it's been found in multiple studies looking at these individuals. A study found that the more extremely vigilant a patient is on a gluten-free diet. So the stricter they are on the gluten-free diet, the more strict that they are and the more vigilant they are will actually negatively affect their social and emotional wellness even more. So this is also associated with anxiety and fatigue. Really, it's important to kind of find that balance. And so this proves to be another hurdle and a challenge for patients and clinicians to get through, as these individuals really have to adhere to a gluten-free diet. And so this is a restrictive dietary pattern that we know just off the bat. And so finding that balance of remaining on a gluten-free diet, but then ensuring that they are able to find some different kind of ways to have a balance with social life, whether it be with family, friends, because we do see so often some patients are extremely scared and vigilant. And we will be discussing hopefully some different ways that they can, incorporate some variety and not feel so, alone. So, as I mentioned, there are so many different aspects of an individual's social life that are affected when they are diagnosed with celiac disease. I always say that all things in life really truly do revolve around food, whether that be, if someone is, in school, whether it be in grade school, in college, the work life balance, again, going out to lunch with coworkers, ordering in, daycare for those younger patients, social events, again, and all of the different travel concerns, whether it be air travel and road trips and things to consider. All of these things are revolving around food. And before a diet is restrictive, some of these things are not even considered in overall quality of life, because an individual can choose whatever they have a taste for or whatever might suit their fancy that day. But when someone's restricted and they are not able to have as much of a variety, it could be very overwhelming. And we know that all family and friend gatherings, whether it's going to a restaurant, a potluck at a family or friend's house, different work meetings, they all are revolving around food. And so many are struggling with, how to make these decisions. And again, really, it's important to find these different ways and to work with different dietitians that specialize in GI disorders. So myself, I am one of many now. It's been a growing group of registered dietitians that work with GI disorders across the country. And so again, that is key, because many of these individuals are finding just so much misinformation online. And so we'll go through some different um, things today, and hopefully that will help with education of these patients to reduce some of that food fear and misinformation when it comes to the gluten-free diet. Another plug for the GI psychologist. We are so fortunate to work with Dr. Elise Bedell here at University of Chicago. She's also been training a lot of GI psychologists through the program, and we're able to refer our patients to her, and she has been so helpful with adherence to the diet, and I can't say enough about it. So here's a reference again with the Rome Foundation, and you can search for one that's near you as well. Again, as I mentioned about being on a gluten-free diet, again, that's already a restrictive pattern of eating, and that is really the prescription, right? So these individuals are not taking any medications. They are following a strict gluten-free diet, or, lifelong. And so there's been more interest looking at that maladaptive eating. And a couple of studies here from Columbia found that those individuals with celiac disease, nearly 80% of those individuals experience some social anxiety, again, around the gluten-free diet and eating out. Those individuals were on the younger end, 25 to 35. They had some more disordered eating patterns and a lower quality of life with regard to following a gluten-free dietary pattern. Another study out of Colombia looked at really the gluten-free diet and celiac disease and its impact on dating life. And nearly 70% of those individuals found that it had a negative impact on their dating life. 40%, approximately 40% were uncomfortable explaining the precautions of being on a gluten-free diet. Almost 30% engaged in, riskier eating behaviors, right? So we always kind of joke of like, oh, wow, you're living on the edge here. But like for some of these individuals, they're, doing things outside of what might be, a safe thing. And they could, again, get sick and have some other further issues from this. Again, in this study, they also found that almost 8% of those intentionally just consumed gluten because they didn't want to be a bother during the date and just didn't want to make anything of it. And then interestingly so, nearly 40% were hesitant to kiss their partner. And then I thought was interesting how to pluck out the fact that 41% of the female individuals were more hesitant to kiss their partner, and 23% of the male that were on the gluten-free diet were hesitant to kiss their partner if they had consumed gluten, which again is something that we get asked very often. And there is a study that is being done at Columbia in New York City right now from the same group, looking at kissing and the concerns and if there is any that might, someone might get from kissing someone after consuming some gluten. So this is a really a hallmark study, but I wanted to take just like a minute to review this for just kind of setting the stage, as there is so much misinformation as far as gluten contamination, gluten contact, cross contact. So when it comes to tolerance, there was a study that was done back in 2007 out of Italy. They looked at how much gluten can be tolerated in those with celiac disease without causing villus damage, or what is the extent. So they did a 0, 10, and 50 milligrams of gluten over approximately 3 months or 90 days. And this is a daily ingestion of gluten. And then they looked to see if there was any villus damage. Now, at 50 milligrams of gluten on a daily basis, it did induce some villus damage in individuals within the study. The safe takeaway, and again, as far as the US, is 10 milligrams of gluten daily should be a safe overall threshold. So as you can see here, Tricia Thompson of the Gluten-Free Watchdog made a visual approximation and weighed out what approximately 10 milligrams of gluten would be from a slice of wheat toast. So you could see here on the plate, this is a quarter at the top of the plate, and you could see all these crumbs on the plate. So combining all of those crumbs together, that would be about 10 milligrams of gluten. So again, kind of setting the stage, being, really staying curious and remaining educated about some of this, as many individuals will worry about, honestly touching a doorknob that someone else touched that touched gluten, right? Or, other small ways that sure there could be, right, someone touching something, but there has to be a little bit more gluten that would be transferred. So again, this, there are, this is kind of that hallmark that we use. So I wanted to touch on this versus the thought that, one crumb on that plate is going to ruin my intestines and I haven't eaten out in 2 years, right? So we want to ensure we have, adequate education about what could cause issues. So when it comes to living gluten-free at home, this is possible in a shared kitchen. I wanted to touch on that. A 100% gluten-free kitchen is not necessary. It's fine to have a 100% gluten-free kitchen, but there are just some different things to be mindful of when it comes to cross contact in a shared kitchen. There are many different things that could be kept it's good to be aware of the things that might be more at risk. So things that might be harder to clean, things like a toaster. So in a very busy shared kitchen, as you could think about a toaster, the toaster, it's very hard to clean it, and you can't really wipe it out because of all the wires in there. There was a small study looking at some of the different cross contact with some of the different utensils, and was found there might not be much cross contact in a shared toaster. This needs to be replicated, and I wanted to touch on, we still are recommending a separate toaster at this time for our patients. Certainly things like a toaster oven could be shared. You can pull the rack out, wash it with hot soapy water, use it in a shared environment. But again, just using some common sense. Muffin pans, if that's going to be used for gluten and gluten-free, just being aware of it could get kind of crusted over the top and it could be kind of stick to that. Another challenging one is going to be obviously like a cast iron pan. Oftentimes it's used for a lot of gluten containing foods. It's not washed typically with like soap and water, and it's often seasoned. Again, have there been studies looking at this? Not necessarily. There's not money in that, but that's something to be mindful of if someone is utilizing a cast iron pan with other people cooking gluten in it at the house, the household. And then again, waffle makers. So again, if someone is using a waffle maker for gluten and then gluten-free, being very aware of really trying to clean that as best as possible, ideally possibly using a separate one. And again, these are some common things that we come across in our clinical setting, working with patients. Other things to consider to separate out as well would be like a strainer if someone's using it in a shared kitchen to strain pasta that has gluten and then gluten-free. Maybe using a separate one, and something like a cutting board as well. If someone is cutting bread and there's a lot of gouges with the cutting board and it's old, considering getting a different one. Certainly, things can be washed with hot soapy water. Again, even in the study, even some things like wiping things down, cold water, removing the obvious gluten source, crumbs, things like that can really reduce it. So another thing in the kitchen would be, watching for things like, butter, nut butters, jams, anything that you would put a knife, a spoon, a fork in and use it in a shared manner, as far as other breads or other kind of products in the kitchen, being mindful of kind of separating those out. Squeeze containers for some of those shared condiments. So a lot of different things like mayonnaise and some other different hot sauces and things such as that, or even fancy mustards are now in squeeze containers versus small little jars that are going to be at a little bit more of a risk of the cross contact. So again, there are so many different things to think about when it comes to eating out. So again, we recommend to really plan ahead, see what the options are, and again, in that calling ahead, and seeing what the different reviews might be online, finding, does this place have a shared fryer or not? That's a big one, especially whether it's like going out for Mexican food and you want to have chips. Well, you want to ensure that the chips are fried separately. So even as someone who also has celiac disease, many of my friends will say, "Oh, Lori, where do you want to eat?" And I'll say, "What about these three options?" And give them some places so at least I could maybe eat the French fries or the chips that might be available. And really being an advocate. So again, speaking up, being clear and concise with your needs, whether it be at the restaurant. And again, that's where sometimes calling ahead, speaking with someone to kind of see what the situation is there, to see if they are also confident they can serve you a gluten-free option. So again, I wanted to touch briefly on some of the different things that we see with patients where if they're persistently having elevated serologies and the challenges surrounding that when it comes to eating out. So or just overall in general. So really assessing the situation and looking to see, is the patient aware of the cross contact when it comes to eating out and at home? Many are actually, might be getting inadvertent gluten in the diet and not purposefully consuming gluten. Whereas upon, questioning, I do have many individuals that will purposefully consume gluten because it may not cause overt GI symptoms. So these are some other reasons why those elevated serologies might persist. Again, oftentimes there might be a change in lifestyle, travel, the different, different items in their, overall diet that they might be consuming. Really looking at the frequency of eating out. If there's 21 meals in a week, if someone eats 3 times a day and someone's eating out for 10 plus meals, that's going to increase their risk of, cross contact. And again, really looking at if there is a shared kitchen. Sometimes going over some of the things with a fine tooth comb to determine, are there any things that you might kind of overlook in that shared environment? Oftentimes, again, we don't have time for this, but someone might be consuming 10 different products in one day of different oat products. And sometimes that could increase the threshold and put them over the edge as far as the risk of cross contact in some of those different oat suppliers, even though they might be labeled gluten-free. So again, some different caveats to think about. And again, shared fryers. Some patients are, don't always avoid those. And that might be a way that gluten could be getting in, intermittently. Another just slide on some common culprits. In the Indian culture, Northern Indian and South Indian, the asafoetida, it's like almost like an onion flavoring. And when they make this powder, it's basically ground and wheat is added to it. So it is nearly impossible to find that gluten-free. So really being mindful of that ingredient, different kinds of, brewer's yeast, autolyzed yeast, extracts, unless it's labeled gluten-free, different seasonings and things eating out, soy sauce based. Some people are eating a vegan diet and not realizing that seitan is not from soy. It's a vital wheat gluten. It's straight gluten. And again, just kind of going over a fine tooth comb of some different things that the individual might be consuming, whether eating out or at home. And so again, some different travel considerations to keep in mind. Individuals need to be able to, pivot. It's not always easy to be as spontaneous as one was prior to eating gluten-free. Really seeing if your hotel can provide a fridge, a microwave as needed, and really arming yourself with different salty and, sweet snacks for flights, road trips to ensure that you are, satiated. And really researching the area for celiac groups or other local recommendations, Facebook groups. Find Me Gluten-Free app is really now, it's international and it started here in the Chicagoland area. And just a slide on balancing the gluten-free diet, thinking of each of the groups as the normal, like choosemyplate.gov, and modifying it for the gluten-free diet. So in conclusion, we reviewed some different challenges of living gluten-free for those with celiac disease, and hopefully we have some realistic considerations and tools in your toolbox to help with adherence for your patients. Really the goal is to help to reduce that anxiety and increase their quality of life. And lastly, really focusing and leaning on all of your different members of the multidisciplinary group. Thank you so much and have a great day.
Guests, welcome back to the team. Thank you so much. Lori is one of our cornerstones here at the University of Chicago in the Adult Celiac Center group, and definitely all of our adult patients and sometimes some of our teenagers as well lean on her. I hope we'll have a lot of fun discussions about some of the things that she's talked about with our team here. And moving on, it is indeed my pleasure and honor to introduce Dr. Dale Lee. He is a person I've known for quite some time and is a pediatric gastroenterologist, director of the celiac disease program at the Seattle Children's Hospital. And continuing with the theme, going to enlighten us a little bit about the challenges and these cross contact that we've been talking about for a while now. Dale, all yours.
Thanks so much, Dr. Verma. It's pretty dark here in Seattle, but I'm excited to be able to join this conversation. There's been some wonderful presentations, And I think a couple of themes that stand out to me are one, the team aspect of providing care, and also this idea of the importance of the quality of life. So my disclosure is one here, and the other disclosure is that I'm a pediatric gastroenterologist. So my objectives today for my 20 minutes is to discuss the balance between rigor and quality of life while on a gluten-free diet, review strategies to prevent gluten cross-contact, and then spend some time discussing areas of uncertainty around cross-contact. So really important right off the bat, want to make sure that we can distinguish cross-contact and cross-contamination. So these terms are used interchangeably quite a bit, and I think people understand what they are, but truly I want to make the distinction. So cross-contact is when a food allergen touches something else, whereas cross-contamination has to do with a pathogen, be it a virus or a bacteria, or some sort of an organism that gets contacted on a food product. So truly, in the sense of talking about gluten touching other food objects, the terminology cross-contact is best. All right, so just a little bit of background from the Food and Drug Administration, and this is my one slide that's kind of a bit rules and regulations-y. So back in 2004, just to understand the landscape, the FDA put forth the Food Allergen Labeling and Consumer Protection Act. So this really specified 8 major food allergens that had to be clearly labeled on food ingredients and on packaging. In 2011, the Food Safety Modernization Act was put forth, and really this was in response to really globalization of the food industry and supply chains, and it was proactive regulation of the food industry. In 2013, very clearly, the FDA defined gluten-free as a voluntary declaration that food companies and manufacturers could make, and really indicated that this needed to be less than 20 parts per million of gluten. And then in 2015, the FDA articulated this concept or the terminology cross-contact as being different than cross-contamination. Okay, so you know the rules and the regulations, but how do you balance the gluten-free diet in terms of what it means to you and your patients? So very importantly, the goals of celiac disease, we're balancing the goals of improving symptoms, mucosal healing of the GI tract, nutritional status, well-being. We want to minimize a few things, including the impact, the negative impact on quality of life. We want to be mindful of the risks associated with active celiac disease. And then, of course, we want to minimize the risk of developing disordered eating. This was a paper from 2014, and I think it really nicely highlights this idea of, so how burdensome is living with celiac disease? So to orient you here, on the x-axis is a visual analog scale. So there were individuals with a variety of different medical conditions, and they filled out this survey. And they filled out 100 as being very, very difficult to live with this medical condition. And they filled out 0 as it's very easy to live with this medical condition. I'll start off with the blue here. So these are individuals with diabetes, and it includes type 1, type 2. 32% of these people were on insulin, and they filled out it's about 40 on their visual analog scale of what it's like to live with type 1 diabetes or type 2 diabetes. In the green here, we have inflammatory bowel disease. This is an autoimmune condition where you have inflammation in the GI tract. The majority of these patients are on immunosuppressive medications, require daily meds, either injections or infusions. So there's quite a bit of medical therapy involved. And they said that their treatment burden of disease was about 30 to 35. And then in the salmon color here on the bottom, we have celiac disease. And as we know, there's no medication used on a regular basis to treat this, but the daily implementation of gluten-free diet, this resulted in a treatment burden score of about 45. And as you can see here, when we compare here, this is greater than for diabetes, greater than for inflammatory bowel disease. The one disease process here that had a greater treatment burden was ESRD, which is end-stage renal disease. And in this condition, people don't have well-functioning kidneys, and oftentimes they require dialysis of their blood. So regularly going into an office to get their blood dialyzed. So as you can see, the burden of living with celiac disease is significant in comparison to other medical conditions. So, okay, so we know that there's a burden here, but is there a way for us to mitigate this burden? So how much gluten ingestion is okay? And I love Lori's presentation where she went through some of the data. I will also go through some of the same studies, but show a little bit more granular detail. So I think Lori set me up really nicely. So this is the Catassi study published in 2007. As she mentioned, it was from Italy, but in collaboration with a group from the University of Maryland. So this was a prospective, multi-center, placebo-controlled, double-blind randomized trial. So people didn't know how much gluten they were getting. So there's 49 adults enrolled. They were micro-dosed with gluten daily for 4 months straight, okay? This first graph here shows their anti-TTG IgA titers. So again, you see the dotted line, which is the threshold of about 7 here. People on a placebo daily, 10 milligrams of gluten daily or 50 milligrams of gluten daily, they did not have a significant difference in their TTG IgA titer. All right, but when they had endoscopy and biopsy, we did see that there were some changes here. So we see for the placebo group that did not get any gluten and for the group that got 10 milligrams of gluten per day, their villus height to crypt depth ratio, or their evidence of mucosal damage from celiac, was not evident. So there were no significant changes to the mucosa of the small intestine with either 0 milligrams or 10 milligrams daily of gluten. But at the dosage of 50 milligrams daily, there was a significant appreciable damage found in the small bowel, suggesting that 50 milligrams of gluten daily is a problem, but 10 milligrams is okay here. So how did we arrive at this 20 parts per million threshold that the FDA told us about? So there's some data that came from Europe here, and it really nicely demonstrates using some calculations how we arrived at this 20 parts per million threshold being safe. So in this study, there was a 10 days of gluten-free diet diary that individuals who were enrolled self-reported. They weighed the items that they consumed. And as you can see here in this graph, we have Italy, Spain, Norway, and Germany represented. On the y-axis is a total intake in grams per day of gluten-free foods, okay? So if you had a gluten-free pizza, they specifically were able to calculate the quantity of the pizza dough that was gluten-free. They didn't count the weight of the toppings here. And as you can see here, it varies from the 10th percentile in Italy of 152 grams per day, 50th percentile, 265 grams per day, and the 90th percentile all the way up to 531 grams per day of gluten-free foods. So the team looked at this data. And what they did was they looked at this data, and as you can see here in the Italy group, the 90th percent of people consuming gluten-free foods consumed 531 grams per day. The 95th percentile, 639. And then 97th percentile, they ate over a kilogram of gluten-free foods per day. And on the bottom here, they looked at different supposed thresholds of gluten in parts per million for the food. I highlighted here in green. So with the assumption of 20 parts per million of gluten in the quantity of gluten-free foods that people were consuming, this would equal what we've highlighted in green here, how many grams of gluten you've consumed per day. So at the threshold of 20 parts per million in Italy, at the 90th percentile, if you consumed 531 grams of gluten-free food per day, at 20 parts per million, you were consuming 10.6 grams of gluten. As you can see going down, if you look at the threshold of 100 parts per million, at that same quantity of 531 grams of gluten-free food per day, you'd be consuming 53.1 milligrams of gluten per day. Again, above that threshold that Catassi demonstrated. So from this data here, we can see that the threshold of 20 parts per million in general is safe for most people, even consuming up to the 90th percentile of gluten-free foods per day, so large quantities. So what is 20 parts per million? Just a quick review. 20 parts per million means 20 milligrams of gluten per 1 kilogram of food object. So if you were to consume 1 kilogram of gluten-free food with 20 parts per million, you would be consuming 20 milligrams of gluten per day. So this was a study a few of us on this call today were involved with, and it was about gluten challenge. And we published on estimated gluten content of certain foods, and I just wanted to demonstrate what exactly is 10 milligrams of gluten in these foods. And Lori showed that picture as well with that coin and the plate and the crumbs. So if we have a food item such as a bagel, this has about 7 grams or 7,000 milligrams of gluten. So 10 milligrams is 1/700th of the bagel. So for a slice of white bread, about 3 grams of weight total. And so 10 milligrams is about 1/300th of a slice. So like Lori demonstrated, it's some crumbs here. And then for a tortilla, 8-inch diameter white tortilla is about 2.5 grams of gluten. So how much is 10 milligrams of this? About 1/250th. So yes, this is a small quantity, but it is appreciable. So just to give a little bit of context of how much is 10 milligrams of gluten. So I'm not going to go through every single one of these, but if you have celiac disease or if you work at a celiac center, these are very common principles that you teach to your gluten-free patients, or you have received this teaching from your institution. It's about washing hands. It's about separating certain kitchen appliances and utensils. And when you eat out, you have to ask a lot of questions. So these are important things that we teach, and it's really at the core of learning to live on a gluten-free lifestyle in a rigorous and thoughtful fashion. But is it the case that all of these recommendations are set in stone, or might there be some room for dialogue? And I think the answer is there is some room for dialogue here. So how certain are we about these recs? I think we're kind of certain, but also uncertain. A lot of these recs are not data-driven. So some areas of uncertainty that I want to cover, we have pots and pans, like how thoroughly do you have to wash these? Can you do shared pots and pans? Toaster, we've touched on that. Can a colander be shared? Can we share spreads, condiments? And is it okay to wash dishes with a sponge? And there's a variety of other areas of uncertainty. So this is a paper that was published, and I thought it was a phenomenal paper, 2020, by Vanessa Weisbrod and Jocelyn Sylvester and team as well. So they looked at a couple different questions. First, they looked at the question of pasta preparation, and then they looked at the question of the toasters. So this is the data from their pasta experiment. So they cooked gluten-free pasta in water. And if they used the shared water from gluten-containing pasta and then gluten-free pasta, you see here that the gluten-free pasta had greater than 20 parts per million for every single sample analyzed. So if they did this exact same experiment, cooked pasta that had gluten, and then cooked pasta in that same water that was used to cook gluten-containing pasta, but then they rinsed the pasta, the gluten-free pasta, they found that none of these had over 20 parts per million of gluten. So simply rinsing the shared water pasta was able to significantly decrease gluten exposures. And then they did another step. So they cooked gluten-containing pasta in a pot. Then they washed that pot with soap and water, and then they cooked gluten-free pasta. So shared pot, just washed with soap and water. Each of these gluten-free pasta samples had less than 5 parts per million. Again, same thing, but no soap, just rinsing with plain water. Same result here. So they found that you could share a pot here and achieve safe amounts of gluten in the gluten-free pasta. And I won't mention here, guys, I'll conclude at the end of this, but one important takeaway is you have to know which assay is being used. And it was an ELISA sandwich exam assay. The next study this group performed was looking at a shared toaster. They looked at a hospital communal shared rolling toaster first. They looked at gluten-free bread run through here, and they found that the gluten-free bread had less than 20 parts per million in this shared toaster. As you can see, these are toasters where something rolls and usually things flop into like a tray. And then the team looked at gluten-free bread toasted in shared pop-up toasters, and they found that none of these 20 samples had greater than 5 parts per million of gluten. So again, suggestive that perhaps in the setting of toasters, sharing is okay. So any interesting finding that challenges or dogma should really be repeated. And here's a study done from Catherine Parsons and colleagues at Brigham Young University in Utah, and they replicated the shared toaster study. So they used 2 different gluten enzyme assays, Sandwich ELISA from Allertech and then R Biofarm. And they looked at a toast gluten-free bread after gluten-containing bread. And as you can see, 30 samples here for the pop-up toaster. None of them were above the threshold of 20 parts per million. Essentially, all of them were less than 5 parts per million. And then they got 10 used toasters from around the community, and they toasted gluten-free bread. And for each of these 30 samples, there was nothing above 5 parts per million of gluten either. So this test substantiates the finding from Vanessa Weisbrod's study. Okay, so the Catherine Parsons BYU group did quite a few studies here, and Lori Wellstead, she hinted at this as well. So one of their other studies was looking at, can you share spreads and condiments? And they looked at mayonnaise, jam, as well as peanut butter. So what they did was they simulated making a sandwich using a container of mayo, jam, or peanut butter. And then they took samples from these containers to see, was there cross contact as you simulated making a sandwich with gluten-containing bread. So this is a bit full here, but I want to point out a few key concepts. So the top here is mayonnaise, and we have two different assays to evaluate for gluten content. The first thing that stands out to me here is mayonnaise. This Allertech assay, we have many, many samples that are above gluten of 20 parts per million here. Okay, so we have some that are above 150. But if you look at this other assay with the R Biofarm, all of these samples are below 20. So this is interesting here. Some assays are showing high gluten content, others are showing acceptable gluten content. As we go down here to jam, we see again, one assay shows one sample having high gluten content, and another assay shows about 5 samples showing higher gluten content. So it's interesting here. In my opinion, the fact that there's one sample suggests that there's some sampling sort of bias that can occur. So if you look at your sample from the jam and you get a big old crumb of bread, you're probably going to have this higher gluten content there. But sort of the rest of the jam looked okay here. And then we looked at peanut butter, which is a favorite in my household. Again, similarly, the majority of samples for both assays less than 20 parts per million, but we did see a single sample from the Allertech assay showing that there was high gluten content. So this is illustrative here. You can see 3 different types of foods that are of different viscosity consistency, 2 different assays, we have variable results. So the Parsons group looked at shared fryers. So what they did was first study was they looked at gluten-free fried foods from restaurants in the community that had shared fryers. And that's here on the bottom left. And they did 2 different assays here. And again, they looked and they found that samples from these shared fryers in their community were all below gluten-free foods in a shared fryer were all below 20 parts per million. So this is interesting because we teach our families shared fryers are high risk for cross contact. And then what they did for their next experiment was they used a home fryer. They fried gluten-containing chicken nuggets 2 times, and then they fried either gluten-free fries, tots, or tortilla chips. What they found was in this shared fryer experiment, there was not significant gluten exposure in the gluten-free food products, except for this tater tots, where they found that it appeared that at least one sample had greater than 20 parts per million. So this is interesting, provocative here. Okay, so what about this variability in gluten assays? Like, can we trust these assays or why are they so different? So this is a study done by Trish Thompson, published in 2021. And the study design for her study was 20 orders of French fries from restaurants with shared fryers in the community. She looked at 2 different types of assays for gluten. One was a sandwich ELISA assay and another was a competitive ELISA assay. So it's just a different approach to trying to answer the same question, different sort of a study. And she found that with these 2 different assays, there's a significant difference in samples with gluten detection. With the sandwich ELISA detecting 9 out of 20 samples had gluten in the range of 7 to up to 80 parts per million gluten, and the competitive ELISA showing only 3 out of 20 samples detecting gluten in the range of 14 to 270 parts per million. So this is suggesting, again, that the type of assay matters as we arrive at these conclusions. Okay, and then what about this question about colanders? So this was a study done out of Switzerland, and it was an interesting study. So what their experiment entailed was they cooked gluten-containing pasta for 10 minutes. They drained it for 10 seconds in a colander. They cleaned the colander by one of these methods here. And then they cooked gluten-free pasta in a brand new pot, but they drained that gluten-free pasta in the same colander that had experienced gluten-free pasta, gluten-containing pasta. And then they measured the gluten content of the gluten-free pasta. So this is interesting here because when they measured the gluten content of the gluten-free pasta, they found that in the unwashed colander, there was not significant gluten above 20 parts per million. Similarly, if they rinse the colander with cold water, no gluten. Rinse the colander with hot water, no gluten. If they clean the colander with a cleaned cloth and towel, there was no gluten. Interestingly, if they cleaned the colander with a wet cloth that had gluten on it, they still found that after the gluten-free pasta was strained, that there was less than 20 parts per million of gluten. So it's very interesting, suggesting that maybe our dogma about colanders can be challenged. Okay, so we personally do use a sponge in our household. This is a study from Japan. And what they did was in their experiment, they washed wheat flour batter, about 10 grams, not milligrams, so 10 grams of wheat flour batter with a sponge. What they found was that the sponge was very efficient at transferring batter if it was intentionally transferred and not rinsed. But they also found that even if you rinsed and cleaned the sponge, about 20% of the residue remained. And they looked at that sponge very carefully under the microscope. And as you can see here, this more luminescent material is that batter that's lighting up, even after you rinse and clean that sponge, suggesting that a sponge could be problematic here. But the data on rinsing being effective, if you clean something but then rinse it, perhaps it's okay. So there are some limitations to the results of our current studies. I definitely don't want people to walk away from here saying it's fine to use a shared colander. It's fine to use a shared fryer. I think there are significant limitations to the current studies that give me pause. First, there's a small number of studies, so studies need to be repeated to be verified. Second, the sample size in these studies is not very large, so it's hard to make a generalizable statement based upon smaller sample size studies. For many of these studies, number 3, investigators were unblinded. So the gold standard is if you can have blinding of the investigators as well as placebo control. So here again, the investigators knew what they were measuring when they were doing these studies. Fourth, we know that there is significant variability in study design. So the brand of colander that you use, the brand of pasta, the type of pasta, how you rinse things, how you prepare foods, these are all highly variable. So we want to be thoughtful about making generalizable conclusions from these studies. And then finally, number 5 is a big thing in my mind. There's significant variability in the type of assay, the brand of assay, and the performance. So there needs to be some work to understand why there's such high variability here. It's hard for me to think about, I can fully trust these assays and have confidence in them if when compared to each other, there's significant differences. So my takeaway from the current studies, they're very interesting, they're provocative, but I'm not suggesting that we should generalize the knowledge from these studies and just take them all to heart and be less rigorous about gluten cross-contact. So how do you approach uncertainty? So in my clinical practice, our approach is first we collaborate with the patient, and for us it's families because we take care of children. We work closely with our dietitian team, and I as the medical provider am part of this dialogue here. We have a discussion about risk-benefit balance. We talk about our recommendations, and then we do some shared decision making. For each family, there are some things that they feel comfortable doing and don't feel comfortable doing. So eating out in certain restaurants where you have less inherent certainty than when you are cooking the foods yourself, that's shared decision making. And our job as a medical team is to be thoughtful and encourage families. Sometimes we have to say, we need to be a little bit more rigorous. In other settings, we want to push people and encourage them to venture out a bit more. And at the end of the day, we have the value of being able to make the assessment for active celiac disease activity. So if there's some uncertainty, at the end of the day, we can go back to seeing, is there active celiac disease given our uncertainty about gluten exposures? So the pillars to monitoring celiac from my team's perspective, we look at symptoms, which include growth and weight gain in children. We look at our celiac serologies like the TTG IgA. Our dietitian assessment for looking for gluten exposures and nutritional adequacy is key. And then finally, we have the tool of endoscopy and biopsy of the mucosa as we monitor for celiac. So in conclusion, quality of life is important in celiac disease. We've demonstrated that this is a big deal. The treatment burden is significant. Second, it's a small amount of gluten consumption at 20 parts per million is okay and does not cause bowel damage. Third, gluten cross-contact is important to consider, but clearly there's some uncertainty here. And additional studies will help us to guide future recommendations. And I'd like to encourage everybody, if you're a patient here or if you're a provider here as well, discuss this with your celiac team about how do we approach these areas of uncertainty of cross-contact, and how do we give thoughtful messaging to families that isn't sort of crossing wires, because I think it's a very confusing topic. Thanks so much.
Thank you, Dr. Lee. And so stick around. We're going to be having the Q&A after one more presentation. As a reminder, get your questions in. Use the function on this webinar to ask your questions, and we'll have a discussion. Our final presenter will be Vanessa Weisbrod, who's the Chief Education and Community Engagement Officer at the Celiac Disease Foundation, where she also serves as the Director of Education. Although Vanessa can't be with us today live, she has pre-recorded her talk on the topic of food insecurity.
Hi, everyone. Good morning. I'm Vanessa Weisbrod from the Celiac Disease Foundation, and thank you so much to Dr. Verma and her entire team at the University of Chicago Celiac Center for inviting me to speak today. Food insecurity in celiac disease is a topic that I'm very passionate about and have spent many years working on building screening resources and support resources for hospital clinics and patient families, and I'm very much looking forward to talking about it with all of you today. So to start out, what is food insecurity? I want to make sure that everyone understands the definition as according to the U.S. Department of Agriculture, because people in the celiac community have different definitions of what it means. But for the purposes of today's presentation, we are following the USDA's definition, which is they define food insecurity as a lack of consistent access to enough food for an active and healthy life. Feeding America projects that 42 million people, which is 1 in 8, including 13 million children, or 1 in 6 children, experienced food insecurity in 2021. Those statistics are relevant to the entire US population, but today we're going to talk about specifically how celiac disease impacts our celiac disease community. So studies have shown that people with celiac disease are at a higher risk of experiencing food insecurity compared to the general population. We believe that the additional cost of gluten-free foods, which we know can be substantially higher, is a major contributing factor. One study from Boston Children's Hospital found that up to 27% of pediatric celiac patients screened positive for gluten-free food insecurity. They did a really interesting study where they screened using the hunger vital signs. And first they screened using the 2 questions. And with just the 2 validated questions, they found that 24% of pediatric celiac patients experienced general food insecurity during the COVID pandemic. But what was really important about what they did is that they actually modified the screener and asked it again using the words gluten-free. And when they did that, the percentage of patients screening positive went up to 27%. Another study found that 1 in 6 celiac patients, including adults, are experiencing food insecurity as well. Food insecurity can have a huge impact on health. It can lead to poor dietary adherence and nutritional deficiencies in people with celiac disease. And limited access to gluten-free foods may at times force people to consume gluten, even though we know that it can lead to adverse health effects and potential complications from their disease. We know from data that less than a quarter of food insecure celiac patients adhere to a strict gluten-free diet. And we know that these patients are likely to have higher healthcare costs, 1.7 to 2.75 times higher, because they are continuing to consume gluten. The economic burden is well documented. We all know that gluten-free foods are more expensive, but this higher cost of foods can greatly exacerbate food insecurity. Studies have shown that gluten-free products are up to 1,088% more expensive than their gluten-containing counterparts. We know that all processed foods across all categories of purchasing are more expensive than their gluten-containing counterparts. Our studies show that these products range from anywhere from 4% all the way up to that 1,088% more expensive. The really sad part is that gluten-free bakery prices are even higher. And when I say bakery prices, I'm talking about specialty gluten-free bakeries. And for those of us in the celiac community, we know that we flock to them. You hear about a new bakery in town opening that's all gluten-free, and it's the first place everybody goes. Unfortunately, the prices at these places are so high that they're really unattainable for people who are experiencing food insecurity. We also know that the nutritional content of gluten-free food is often poorer than conventional foods, which also contributes to the poorer health outcomes. So I want to take a second and compare grocery receipts. So on the left-hand side, you see a grocery receipt for gluten-containing products, and on the right, the grocery receipt for gluten-free products. So first we have bread. On the left, you see that a 20-ounce loaf of bread costs $3.64. The gluten-free loaf, which was only 14 ounces, costed $5.69. And so as we go through these, I want you not only to think about the increased cost, but the dramatically lower amount of food that you're getting for a higher price. So for the bread, the gluten containing was only 18 cents per ounce compared to 40 cents per ounce on the gluten-free. You see this trend all the way down. For pasta, you get 16 ounces for $1.84 compared to only 12 ounces for $2.62 on the gluten-free side. Mac and cheese, the regular version, $1.24 for 7.25 ounces versus $3.26 for only 6 ounces. The gluten-free flour is perhaps the worst of the bunch. You only get 22 ounces of gluten-free flour for $4.87 versus on the other side, you get 80 ounces of flour for $2.38. So it's more than double the price for 1/4 the amount of product that you're getting. The same with pancake and waffle mixes. You get 4 times more product for a much higher price. So you can see just from these 5 examples that the diet is not only more expensive, but you get far less product for a whole bunch more money. And so it's a really big challenge for these families who are experiencing food insecurity, that they're not just replacing their gluten-free bread, but they actually have to buy more loaves of bread to make the same number of sandwiches for a dramatically higher cost. I've actually had experiences where parents have said that they started making their child only half a sandwich so that they were only going through 1 slice of bread versus the 2 slices to have a top and a bottom piece because the cost was so dramatically higher for that loaf of bread. Because of these costs, we know there is a huge impact on adherence to the gluten-free diet. That Boston Children's study that I mentioned found that 1 in 10 households with a child on a gluten-free diet reported intentionally ingesting gluten because of limited access to gluten-free foods. That intentional ingestion doubled during the COVID-19 pandemic, and it went up even more when there were multiple household members following a gluten-free diet. We know celiac disease is genetic and that many times there are more than 1 household member with celiac disease. In my own household, this is true. I have celiac disease, as does my 11-year-old son, and this is very common in families with a child with celiac disease. So what do we mean by limited availability? So first, that kids do not have access to gluten-free meals at school, which if your child goes to a public school, this is actually illegal. The U.S. Department of Agriculture requires that any school who participates in the National School Lunch Program make gluten-free meals available to students with celiac disease. So what this means is that if your school provides, or your patient's school is providing meals to other students, they must provide gluten-free meals as well that meet the needs of a child with celiac disease. If you live in one of 8 states in the United States that offer universal school meals, your child is entitled to free breakfast and lunch at school that is gluten-free. And I know that probably sounds overwhelming and that there's a lot of fear around eating gluten-free at school, but there are so many schools across the country, thousands that I've worked with personally, that are successfully offering gluten-free meals to students with celiac disease. And so if your patients or your children are not currently enrolled in these programs, it is the easiest way to help cut costs, that you can get 2 meals. If you live in a state with universal school meals, they are completely free. If you live in a state that does not have universal school meals, you can apply for the free and reduced meal programs, where you can get them free or at a reduced cost. The other important thing to note is that schools cannot charge a child more for a gluten-free meal. So even if you do pay for lunch at school, that price is capped at the same price as what other students are paying. There are also a very limited number of products available through the WIC program, and so this is another barrier that patients face. There are limited SNAP benefits that don't account for the cost of the gluten-free diet, and we know that very few food pantries stock gluten-free food regularly. So I want to take a second and dive deeper into federal benefits. So as I mentioned, state and federal food assistance programs do not account for the increased cost of gluten-free food. So you don't get additional benefits because the gluten-free diet costs more, which is a huge problem for families with celiac disease. The WIC program actually requires that bread and cereal products be made from whole wheat or have other requirements. To dive a little deeper into this, these are the actual pages from the requirements for breads and grains in the WIC program. So the bread products, they must contain whole wheat, or if they're made from other grains, and there are gluten-free grains that are allowed, they are not allowed to have any added fats, oils, sugars, or salts. And the problem with this is that there is not one single gluten-free bread out there that does not have one of these things added to it. And the reason is that they need to add these items, sugars, fats, oils, and salt, to make them taste better and to make them have a texture and consistency that is palatable for people. And so this is a huge problem, that people who are part of the WIC program cannot use their benefits to get gluten-free bread. And we know that gluten-free bread is one of the most desired items for people with children with celiac disease. Finally, free and reduced breakfast and lunch programs, they don't actually reimburse schools for the increased cost of gluten-free food, but again, they don't allow them to charge more. And so this can be an issue for schools and just being able to maintain and continue operating with the higher cost of food. So as I mentioned, there are very few options at most food pantries. Most of them do not regularly stock gluten-free products. Oftentimes when they do have gluten-free products donated, they're put into the general supply. And they're typically an unreliable source of food for patients with celiac disease. Why this happens? If you talk to a bunch of food pantries, they'll tell you, we didn't know that we needed to stock it. And so I know many of you are healthcare providers who are watching today. The number one piece of advice that I can give you for helping food pantries is for you to form a relationship with 1 or 2 pantries in your area and start a referral program where you let the pantries know when you have a patient that screens positive for food insecurity, by simply letting them know and letting them have an idea of how often these families are going to be coming to get food. They can start to think on their administrative side of how to set gluten-free products aside, how to ask for gluten-free products in food drives. And so you making that effort to have the relationship can actually really help these food pantries start to become a resource for your patients in the community. So finally, we know that there are psychosocial effects related to food insecurity. The stress and anxiety associated with managing a strict gluten-free diet and dealing with food insecurity can have significant psychosocial impacts. Dr. Pinto Sanchez and her team actually presented a really interesting study on this at Digestive Disease Week this past year, where they showed that compared to food-secure celiac patients, the food insecure population had a significantly reduced quality of life, as well as increased anxiety and depression. And so this is definitely something that you want to keep in mind as you're working with families who are experiencing food insecurity, that you're thinking about their emotional well-being as well. So now I've talked a lot about the negative things, but how can you as healthcare providers help this population? So first and foremost, you can start by screening for food insecurity in your clinic. The Hunger Vital Sign is a validated 2-question screening tool that is used to identify patients who are at risk of food insecurity. They are 2 very simple questions. Within the past 12 months, we worried about whether our food would run out before we got money to buy more. And second, within the past 12 months, the food we bought just didn't last and we didn't have money to get more. Now, based on the Boston Children's study, I would recommend that you ask these 2 questions, and then you ask 2 more questions where you have the exact same 2, but you add the words gluten-free before food. So you would say, within the past 12 months, we worried whether our gluten-free food would run out before we got money to buy more. And within the past 12 months, the gluten-free food we bought just didn't last and we didn't have money to get more. This way, you're not missing families who are experiencing specific gluten-free food insecurity. So the responses to the screeners are often true, sometimes true, or never true. If a patient answers often true or sometimes true, this is considered a positive screen. And in these cases, we would want to refer them to social work for a needs assessment and provide resources for helping them to access food. If they answer never true, this would be considered a negative screen, but what we know is that food insecurity is not just one point in time and that it can happen at any point. And so it's very important that this screener is not just a part of a first visit, but it's something that you ask at every single follow-up visit. At Boston Children's Hospital, they asked this screener at the gastroenterology visits, at the dietitian visits. They ask it as part of registration for their educational programs and as part of enrollment in their patient and family support group. And so it's really important that you're asking it at multiple points. Most often, these patients are not going to screen positive at the very first visit with the gastroenterologist. And the reason for that is that many of them at that point have not had time to go grocery shopping on a gluten-free diet, and they haven't really seen how this increased cost of food is going to impact their family every day. And so you're typically going to see these positive screens coming in at the first follow-up appointment or, 3 months, 6 months after diagnosis, if it's specific to the gluten-free food causing the food insecurity. So other ways that you can help support these families, enrolling them in school breakfast and lunch programs is such an important thing to do. If they can get free breakfast and lunch that's gluten-free at school, that's helping the family offset the cost of 2 meals a day, 5 days a week. And so that is a huge help, especially when those 2 meals consistently consist of increased cost foods. So, my son's school, for example, for breakfast, he has access to gluten-free muffins. He can get gluten-free pancakes and waffles. And those foods are all actually part of his school district's normal ordering process. This isn't an extra bonus cost for the school. They're on their already approved list of products. And so he can get individually wrapped gluten-free muffins or again, pancakes or waffles, as well as Chex cereal. So that's a huge deal. For lunch, he has access to foods like a gluten-free sandwich on gluten-free bread. He can get a gluten-free bagel, chicken tenders, pizza, gluten-free pasta. Again, all of these things are available to him free of charge because we live in a state that has universal school meals. Again, I know that families can be hesitant to want to enroll in these programs, but with a little bit of dedication and work, having your social worker, having your dietitian meet with the school cafeteria, it is possible to find safe ways to feed kids at school. I already mentioned forming relationships with food pantries, and this is something that I encourage all of you to do. It's such an easy, simple thing to work on, and food pantries are very receptive to working with hospital centers. And by just knowing, again, how many patients need food and that they're coming, they can start to plan for having gluten-free food set aside for these families. Also making sure that the families are enrolled in SNAP and WIC. I know I mentioned that it's hard to utilize the benefits for gluten-free food, but the hope is that families can get all of the naturally gluten-free foods through these programs. So fresh fruits and vegetables, all of their produce, proteins, chicken, fish, beef, all of these things are available through these programs, and naturally gluten-free grains like rice. So it's very important that you don't skip enrolling them in SNAP and WIC. Grocery stores are also very willing to help with food insecurity. And so I would recommend talking to your foundations, to your philanthropy arms at your hospitals, to talk to them about reaching out to grocery stores for gift cards. And this can be a really great way to help support families by just giving them a gift card to purchase groceries with. Finally, it's really important to understand the needs of a specific family. So families experiencing food insecurity have very different needs, and one size does not fit all in food insecurity. And so it's important to understand their social needs, their cultural needs, and really think about how those play a role in how they are adhering to the gluten-free diet. And so I would encourage you to ask questions of them to make sure that you're getting the full picture of how these pieces of their life impact their diet. So now, how is the Celiac Disease Foundation helping? So we have launched the Celiac Disease Food Insecurity Resource Network, and the goal of this program is to help hospital centers in supporting food insecure families with celiac disease. And we are very grateful that this program is supported by many generous donors, as well as from fundraising programs through Celiac Cruise and corporate sponsorship from Crunchmaster. So how this program works is that every month, families who are enrolled in the program receive a box of food that is put together by a group of dietitians. The box is really meant to offset all of those specialty gluten-free food items. And so patients will get things like gluten-free bread, pasta, tortillas, snack foods, things that could be paired with the naturally gluten-free foods that they can get from their local resource programs. We also offer training for clinicians on how to screen for food insecurity in the clinic. Every patient that's enrolled in our food insecurity program receives monthly nutrition education and cooking classes, all available free of charge. We also help them with enrolling in state and federal aid programs to make sure they're able to maximize their benefits. And we're also doing research. So we don't want to just be sending food to these patients and never learning from them. And so every month, these patients complete surveys so that we can learn, is this box of food helping them? What are other culturally relevant foods that they want to be getting? How is their food insecurity status changing during the period that they're enrolled in the program? And so we're really hoping to keep learning from these families so that we can improve how we support them. So on this screen now, you see current programs that are enrolled in our CD Fern program, as well as programs that we are getting up and running. My hope is that by this time in the University of Chicago's program next year, this slide will be so full of logos because we have many, many, many more hospital centers who are participating. If you don't see your hospital center up here now and you are interested in enrolling to get support for your food insecure patients, you can email me at vanessa.weisbrod@celiac.org, and we can work on getting some slots opened up to help your patient families. So again, I just want to say thank you to Dr. Verma and her whole team for inviting me here today. I'm sorry that I can't be with you all live, but hope that I have shared some information about food insecurity that will help you in your clinics and offer some resources to you for supporting these families in the future.
Thank you, Vanessa. At this point, I would like to invite everyone from the morning session to join us for our Q&A. I know it's sort of abbreviated a little bit, but I do believe that we've shared a lot of good information. And just for the providers who are on this forum here today, please remember you can get involved for your patients with all the food insecurity and everything else that Vanessa was talking about, and everyone else. So please get involved. So first question that we'll take from the Q&A, Dr. Ann Lee, since we have two Lees, Dr. Ann Lee. The question is, what are the specific nutritional content recommendations that you would have for someone who's going to the grocery store? Like, what do I pick out in a practical way? What do I read? What do I read on the labels besides it being gluten-free? What else should I focus on? What else should I be telling my patients to focus on when they're going shopping? And I would love to hear from everyone else as well after Dr. Lee's answers. Thank you.
The first thing we would recommend would really, and it's a great question because we want to educate our patients to really do the best. But in light of what Vanessa was talking about, I'm really going to emphasize, let's look at filling that grocery cart with the naturally gluten-free foods. You know, the gluten-free products do tend to have more fat, more sugar. They don't meet some of the qualifications for the different food programs. So if we look at really, you know, your fresh fruits and vegetables, your lean proteins, and that would include less expensive proteins like your beans and such that can easily be fit in. But we don't live by meat and veggies alone. So we need to look beyond that. So what we look in that carbohydrate section is, again, naturally gluten-free options. You can do rice, you can do potatoes, you can do grains like millet and quinoa that have high nutritional content and yet are not as expensive as your packaged processed things. When you go to the packaged food, what we're looking for is we want to make sure that there's fiber in the product. I always tell my patients, look for at least a couple grams of fiber in each serving. Look to see how much added sugar is in the product. You're looking for, you know, a natural sugar I'm not as worried about. We're looking to minimize those added sugars to the product and to the fat content. If you can and have time, because I know sometimes grocery shopping is very busy, especially if you're shopping with family members or kids, that if you can scan that list of ingredients, you're looking for whole grains. You're looking for brown rice instead of white rice. You're looking for if they have added any millet, any sorghum. With the question of oats, we always guide our patients to look for the distinction of that it's gluten-free oats in the ingredient list. So in summary, we're looking for fiber, we're looking for whole grains, and we're going to emphasize naturally gluten-free foods.
Thank you. And Sadie, anything to add from a child perspective?
I would actually echo exactly what Anne just said, because those are all great tips of not only establishing a much more naturally gluten-free diet, and then also working towards being familiar what is in our gluten-free packaged food products. You're going to start to, you know, be a little bit maybe conscientious of your dietary choices, and considering what I would say from a pediatric population is be thoughtful a little bit about the serving sizes as well. So paying attention to that very top part of the nutrition facts label that does say this is the suggested serving size, and then going back down, you know, looking at your dietary fiber and your added sugar content when it does come to the pediatric population.
Thank you. Ben?
Okay, so why don't we pivot to perhaps the Colorado group, maybe for Dr. Stahl, but really the others could weigh in. Curious about monitoring for additional autoimmune conditions. You'd mentioned that there's some increased attention being paid to these antibodies against islet cells for the development of type 1 diabetes, and maybe it's warranted to look for those. I'm wondering about thyroid. So that's a common autoimmune condition. You mentioned a thyroid stimulating hormone. There are other antibodies that are sometimes checked, and sometimes we get these. Someone else checked them, like anti-thyroid peroxidase or other markers of thyroid autoimmunity. What should we be doing when we see those appearing? Should we be checking those, or does it just cause undue anxiety without anything we can do about them?
So I think that's a really, really good question about how to best screen for thyroid disease and whether we should be looking at autoantibodies for thyroid disease. You know, some of the literature that looks at concurrent autoimmune thyroid disease and celiac disease, they have reported prevalences of up to, you know, like 26%, which is a huge prevalence, but that's when you screen based on autoantibodies. And I think the significance of those, you know, is actually really, really hard to say, because sometimes people are positive and there's no impact on thyroid function. And so what we should be doing with those positive test results, good question. I'm asking, you know, my friendly endocrinologist when I get that back. and also checking thyroid function to see if there's any implications for hypo or hyperthyroidism with that positive result. Now, the utility of those autoantibody testing results, I think is a good question, because when we're thinking about screening for concurrent autoimmune diseases more broadly, sometimes it's easier and better and cheaper to just lump them all in together, right? You can run multiplexed assays that will give you thyroid results in addition to islet autoimmunity, in addition to TTG. And so when we think about screening at a population level, there may be some benefit to checking those autoimmune thyroid antibodies. But I think we just don't know the exact clinical implications of that yet. And we really do need more studies in that area.
So, Marisa, I know that when I am seeing patients, and I'm assuming a lot of other pediatric gastroenterologists get that same question, with this whole association between type 1 diabetes and celiac. So often the question is my child going to end up with type 1 diabetes? So diagnosed with celiac disease, are they going to end up with type 1, and when? I know it's kind of hard to predict some of these things, but I'd love to hear what you have to say. And then maybe Dr. Dale Lee, what do you tell your patients?
Yeah, so what I tell my patients, because I talk to every single family about the risk of diabetes with celiac disease, and I always start the conversation with, I really do not want you to take away from this conversation that your child is going to get diabetes, because that's still rarer and far and few between. And so I don't want that to be the take-home message from this conversation. Some studies suggest anywhere from 1 to 1.5% of children with celiac disease will develop clinical type 1 diabetes. But I think it's important to talk about ways that we can monitor for risk. And we're fortunate enough to have islet autoimmunity screening, which tells us about risk of type 1 diabetes. And so for type 1 diabetes, we know if you have multiple islet autoantibodies that there is a much higher risk of progression to type 1 diabetes. And now there are interventions to help delay that progression. So I think it's a good thing to be screening for that so that you can know about your child's risk. This is not part of our formal recommendations, but what is part of our formal recommendations is to talk about signs and symptoms of diabetes. So of course, if your child were to develop, increased urinary frequency, and by that, that's not just a little bit of peeing more often, but like having to wake up in the middle of the night and run to the bathroom when before that wasn't happening. Or, and this is always an interesting symptom to talk about here in Colorado, but if patients are thirstier, and that's not when you're going out to the mountains and skiing all day, but really drinking like liters of water and still thirsty, those are things we would want to hear about. And those would be reasons to screen for diabetes with a hemoglobin A1C. But I do think it's important to talk to families about the options for islet autoimmunity screening.
Yeah, I agree with Dr. Stahl. And, I'd had this discussion with our endocrinologist early on. So a few years ago, the question was, I have a lot of patients that say, do I need screening for type 1 diabetes? Because a lot of people were asking, can I get a hemoglobin A1C with my annual celiac labs? And I'd had this discussion with our endocrine team, and the answer at that time was hard no. Like if you're going to develop type 1 diabetes, what's going to happen? You're going to have high blood sugar levels. If you have high blood sugar levels, you're going to pee a lot. You're going to become very thirsty. You're going to lose weight. So there are very overt symptoms that you can see. So I had a recent dialogue, and so the game changer now is there's a therapy, sort of a monoclonal antibody therapy for people that have islet cell autoantibodies. So the risk of going on to develop type 1 diabetes. So this is sort of newer. And we have not used this much in our institution, but the dialogue is now going to change about we can do this proactive screening. The question is so at what age and at what sort of stage of gluten-free diet do you do this screening? And how frequently do you do the screening? So We are in the process of developing a protocol in our institution, and it's going to be likely about a year after 6 to 12 months after you've started a gluten-free diet. We're going to offer with shared decision-making auto islet cell antibody screening. And for families to know, if you screen more than one positive, you're going to go to our endocrinology team, and they'll have further discussions about this medication called teplizumab, which can potentially delay the onset of type 1 diabetes by like 2.5 years, and decrease the risk of things like diabetic ketoacidosis. So I think the landscape is changing, and our institution is just starting to institute some of these changes.
Thank you. And Dr. Lebois, being an adult gastroenterologist, what do you face the same questions in your patient population with celiac disease, questions about diabetes and things like that?
I would say, thanks. I'd say there's less concern about developing type 1 diabetes among adults with diagnosed celiac disease, simply because risk of islet immunity and type 1 diabetes really goes down in adulthood. It does happen. If a patient getting their annual celiac-related labs wants a hemoglobin A1C for me to throw in, I mean, that's one of these things that we often include as routine health maintenance. It's very easy to do. And so there's no problem doing that. Of course, it's more looking for type 2 diabetes, which, while not clearly associated with celiac disease, is common enough that we look for it in any adult seeking healthcare. As for the other autoimmune conditions, there's no hard proven list of things that are established in terms of what to search for, but I think it's practical to include annual liver enzymes, right? It's a good way to look for celiac hepatitis or the various immune-related liver diseases that celiac may increase the risk of, and that's often part of routine labs anyway, and a TSH, a thyroid-stimulating hormone. Beyond that, I don't start looking for other immune-based problems unless a patient is commenting or noting symptoms. If someone says, I've got a lot of dry mouth lately, dry eyes, it behooves one to check for Sjogren's syndrome-related antibodies. That's not screening. That's reacting to symptoms. And I do think that for people with celiac disease, because of these relationships with autoimmune conditions, we should just have a lower threshold to test when someone mentions something. Because of that association. But I don't push for just looking for it by doing a whole long panel, because then your risk of a false positive in a wild goose chase goes up, and that doesn't do a good service to our patients.
And I guess from a quality of life standpoint, so I think if we continue with this theme of looking at other autoimmune diseases, Dr. Germoni, do you see that as you're part of the Colorado Center, since there are so many more of these antibodies that are being checked and so on, do you find that there is a heightened anxiety now, or is it more that people are, okay, now I've got a tool that I can, work with? Is that something that you've seen over time?
Yeah, thanks for checking in and asking about quality of life, one of my favorite topics. Yeah, I actually have seen a lot of the benefits of having a tool available. A lot of families kind of wondering and now can either be reassured or feel that they have that tool available to them. And I would say in our practice, we really haven't had any families that have really expressed concern or any kind of negative response to those pieces. And I think our medical providers do a fantastic job of really doing, as Ben has described too, like not doing like a full, complete, massive amount of testing. It's really targeted as well and supportive of the family. So yeah, I think there's a pretty good balance so far in our team.
So we're not creating more hypervigilant people. That's good. And, I think as if you're not a gastroenterologist or you're not part of a team in a celiac center, what would everyone suggest to folks? Send to a celiac center or just support these looking for, or as Ben said, as symptoms come on, you test particular people and so on. How do we support an adult gastroenterologist or pediatric gastroenterologist who's not part of a team? Who wants to take that one?
So I can start with the pediatric perspective and just want to communicate that even if you're not a part of a center like our center here, There are national resources for this. So you definitely do not have to feel alone when you get a positive result, and there are places you can go. So I'll speak specifically to islet autoimmunity screening. There is the ASK program, or autoimmunity screening for kids, and specifically the Ask the Experts program, where now islet autoimmunity screening is actually available nationally through ASK. So regardless of whether we're talking to our patients about it, families are finding it and maybe coming to you with a positive result. But I think it's important to know that you can go to these national resources like Ask the Experts for recommendations of what to do with a positive result, so that you're not having to own positive islet autoimmunity screening as a gastroenterologist. And the goal of these national programs is not to assume care for, patients in Chicago who test positive in Colorado. The idea is to help walk you through like what tests need to be sent more immediately, and then connect the family with providers in that area who can help them. And so, yeah, I think the first step from at least the pediatric perspective is to know that you're not alone and there are national resources for this.
If I may, I would add on the adult side, similarly, we've got a referral center at the Celiac Disease Center at Columbia, but we recognize we can't see all 3 to 6 million Americans with celiac disease. We just don't have the capacity, and we really do need to strengthen the infrastructure of expertise in celiac disease. So there are a number of national resources. You heard about them here. Vanessa Weisbrod in her presentation had some links. Many of those are patient and community focused. I would also add for healthcare practitioners who want to join the ranks of celiac disease expertise, the Society for the Study of Celiac Disease, SSCD, which Dr. Verma is the president of, has it's this member-based organization, has quarterly webinars, a lot of educational materials that members have access to. So we really do want to strengthen the community. The way it works in gastroenterology for adults is every hospital or practice has an expert in inflammatory bowel disease, Crohn's disease, ulcerative colitis. That's not the case for celiac disease, even though celiac disease is as or more common. And so we want to change that. We recognize that that's going to take some work, but hopefully these programs will help foster that.
Thank you. And I guess from our dietitian colleagues, we need, obviously right now, that's the diet that we have. And you set up the stage very nicely for our session, but where do if I am not in the world of celiac disease, how do I help my patients?
And actually, I was going to jump in and say before I get to the dietitian part, for any of our healthcare providers that are listening, just reach out to SSCD, reach out to your other health colleagues within the hospital setting you are. We don't have centers nationwide, but that doesn't mean that you can't start a group at your local hospital. Reach out to CDF, reach out to SSCD, and really get connected with people and start forming your own group in your local hospital, because the more you have a team, the easier it's going to be to care for our patients, because our patients don't present with just GI issues. It's nutrition issues, it's quality of life issues. It's so many that you need to create your team no matter where you are. From a dietitian point of view, if you're new to this field, there is as Lori had mentioned, within the Academy of Nutrition and Dietetics, there is a subgroup of dietitians in GI disorders. It's called the DIGIT subgroup. You can become a member of that. And there are even many resources within the Academy and within the subgroup that could be used as your references for patient education. We have a whole toolkit that was the initial standard assessment. Our new paper has kind of taken that much further, but there are tools that are available through the Academy, but also through CDF. You also have dietitian tools there as well. So there's many, many, many resources.
Thank you, Anne. And thank you to all of the speakers. Looking at the time, it looks like it's time to wrap up. And so stay tuned. We'll be taking a break now and then resuming at 10:55 a.m. Chicago time for session 2 called Monitoring Compliance and Healing on a Gluten-Free Diet. Thank you again and see you soon.
Thank you all. Thank you, Dr. Lovell. And please, everyone attending, there is a new link for the second session. We look forward to seeing you in a few minutes. Thank you. Thank you to our speakers. You were all amazing. And Dr. Lovell for moderating with Dr. Verma. We really appreciate it. Thank you all. We'll see you guys soon.